Good afternoon and welcome everyone to the Senate Committee on Health and Human Services for the 83rd Legislative Session. Madam Secretary, please proceed to call the roll.
Senator Lang, Senator Stone, Senator Taylor, Senator Titus, Chair Doniate.
And I'm here. Thank you so much. Everyone is present. Good afternoon, and thank you so much, everyone, for coming here today. Today, we have 5 bill hearings. That's on Senate Bill 348, 349, 337, 312, and 192 in that order. And then we also have a work session to get through today. Please note for a few housekeeping items, agenda items may be taken in a different order than listed, or 2 or more agenda items may be combined. If you wish to testify today, we ask for folks to please sign in at the table by the door and provide a business card to the committee secretary. And if you do not wish to testify, you may still want to sign in so that there's a record of who is interested in a particular bill. When testifying today, please turn your microphones on to speak and off to listen. And we have listeners and viewers in Las Vegas online, and we are recording this meeting. We ask that public comments be kept to 2 minutes so that everyone interested in speaking can be accommodated, and we can get through the agenda in a timely fashion. And finally, we ask for folks to please turn off their electronic devices, especially cell phones, or put them on silent mode. So talking about the logistics of today, as I mentioned, so we're going to do the work session first because we have all the members here. And then followed by we will do the bill hearing on Senate Bill 348 and 349 while we have Senator Pizzino with us. Then we'll do 337, which is by Senator Lang, and then 312 by Ms. Wilson. And then last but not least, I will present Senate Bill 192. So that's hopefully the plan for right now. So let's go ahead and begin first with the work session. And so we are going to start with the work session document. So if you give me 1 second. So let's go ahead and begin with our first work session document, which is Senate Bill 43, and I'll turn it over to Ms. Cooper.
Thank you, Chair. Destiny Cooper, Committee Policy Analyst, Research Division, LCB, for the record. As legislative staff, I cannot advocate or oppose any of the proposals that come before you today. Senate Bill 43 revises provisions relating to environmental protection. It was heard on February 18th and sponsored by the Senate Committee on Health and Human Services on behalf of the Division of Environmental Protection of the State Department of Conservation and Natural Resources. Senate Bill 43 revises the powers and authorities related to environmental protections of certain district boards of health and health districts acting as solid waste management authorities or administering and enforcing provisions governing public water systems. The Nevada Division of Environmental Protection of the Department of Conservation and Natural Resources proposed an amendment that was presented at the bill hearing. The key provisions can be found summarized on the bill page, and the full amendment is attached. Thank you.
Thank you, Ms. Cooper. Members, are there any questions on the bill? If not, I'll go ahead and accept the motion to amend and do pass this bill. We have a motion from Senator Lang. Do I have a second? Second from Vice Chair Taylor. Any discussion on the motion? Senator Titus.
Thank you, Mr. Chair. I'm going to be a no on this bill. Thank you.
Thank you. Any other discussion? All those in favor of this bill, please say aye. Aye. Any nays? We have a nay from Senator Titus. Motion's carried, and the bill will be assigned for the floor statement. I will go ahead and take it. Let's move on. So that was, again, amend do pass with 1 nay from Senator Titus. Let's move on to Senate Bill 138. Ms. Cooper.
Thank you, Chair. Senate Bill 138 makes revisions governing Medicaid eligibility and enrollment for certain infants. It's sponsored by Senator Cannizzaro, and it was heard on March 11th. Senate Bill 138 requires the Department of Health and Human Services to establish under Medicaid certain provisions. However, there was an amendment proposed during the hearing that replaces the current language of the bill and can be found attached. Thank you.
Thank you so much. Any questions from any of the committee members? Senator Titus.
Thank you, Mr. Chair. One of the things that I was very concerned with on this bill, although I absolutely support in concept that the presumptive eligibility and enrollment in Medicaid for these NICU babies, I worried, and I asked the question during the hearing about the fact that if they didn't sign with Medicaid, it would be part of their licensure. And so I was very concerned about that mandate, and until I have a clear understanding of that part of this bill, that I'm going to have to be a no on it.
Thank you, Senator Titus. Just as a quick response, from my understanding is that the bill with this amendment would be drafted essentially that they would have escalation procedures similarly to how we've done with other bills in terms of issuing corrective action and so forth before it escalates to revocation of a license. But your sentiments have been heard, and I hope maybe that answers your question. So.
Thank you. So I'm still going to be a no, but it's always fun to change your vote to a yes. I never have to argue with that if I see a better bill. Thank you.
This is going in the Medicaid chapter. I don't think it would be license revoking. It would just be like their participation in Medicaid that would be an issue.
Got it. Did Mr. Robbins, can you share that, please?
Eric Robbins, LCB Legal, for the record. I just wanted to note that this bill goes in 422, not 449, and so there aren't. It's not the hospital regulation chapter.
Hopefully okay. So just to be clear,
Although.
during the testimony, and I want to make sure I'm talking about the correct bill. We are talking about 138. This is presumptive eligibility for infants, and during the testimony, we did discuss whether or not the hospital, the mandate was for the hospitals to make sure that they are signed up with Medicaid and make sure these infants are automatically enrolled under presumptive eligibility, correct?
Yes.
Okay.
Actually, so just to clarify, so that part, again, it goes in 422, and so the enforcement would be the ability of the hospitals to participate in Medicaid, not necessarily their licensure. However, there is this NICU Parents Bill of Rights, which would go in 449A, and so that probably would be subject to the 449 penalties, which are, normally it's not a, as the chair said, it's not, they don't normally start out with a license revocation. That's like a pretty severe penalty, and most of that is taken care of through corrective action plans and things like that.
Okay, thank you for the clarification. I'm still going to be a no. Thank you.
Thank you. Any other discussion? Senator Stone.
Thank you, Mr. Chairman. I share the same concerns as my colleague, but I'm going to be doing the reverse. I'm going to be voting yes because we had a commitment, I think, from the author that she was going to mitigate those concerns, and I believe that they may have been or will be, and so I'll just reserve my right to change my vote on the floor.
Thank you so much. Any other discussions? Moving on to the vote, all those in favor of amend do pass on Senate Bill 138, please say aye. Aye. Oh, did I take the motion already? Oh, sorry about that. Too fast. Too fast. I'll go ahead and take a motion on the bill.
So moved.
We have a motion from Vice Chair Taylor and a second from Senator Lang. Moving on to the discussion, all those in favor, please say aye. Aye. Any opposed? We have a nay from Senator Titus. The motion's carried, and I will go ahead and assign that to Senator Cannizzaro. Again, that's an amend do pass on Senate Bill 138. Let's go on to Senate Bill 185. Ms. Cooper.
Destiny Cooper, for the record. Senate Bill 185 revises provisions relating to Medicaid reimbursement for care of disabled or chronically ill children. It's sponsored by Senator Taylor, and it was heard on February 18th. Senate Bill 185 requires the Department of Health and Human Services to reimburse a family member of a recipient of Medicaid for providing personal care services covered by Medicaid to the recipient in certain circumstances. I do want to note there was an amendment, but I do want to note the intent on this because it wasn't necessarily carried out through the amendment, but legal intends to clarify the language. The intent of the amendment is to clarify that the reimbursement for personal care services for family members will be provided under the same conditions as reimbursement for personal care services provided by other persons. The amendment requires Medicaid to provide reimbursement for personal care services, including without limitation, personal care services provided by a qualified family member. Thank you.
Thank you so much. Committee members, any questions? We have the motion to amend and do pass from Senator Titus. Do we have a second? We have a second from Senator Lang.
Hurry up and vote.
Any discussion? Wow, suddenly time is going by really slowly. All those in favor, please say aye. Aye. Any opposed? The motion's carried, and I'm going to assign that floor statement to Senator Taylor. Let's move on to Senate Bill 207. Ms. Cooper.
Destiny Cooper for the record. Senate Bill 207 requires the establishment of a program of all-inclusive care for the elderly, otherwise referred to as PACE. It's sponsored by Senator Taylor, Donyate, Senator Neal, etc. It was heard on March 11th. Senate Bill 207 transfers the authority to establish and administer the program for PACE from the Aging and Disability Services Division of the Department of Health and Human Services to just the department. There was an amendment proposed. Senator Taylor proposed an amendment at the bill hearing on March 11th, which would remove subsection 2B from section 1, removing the requirement that PACE programs be conducted at federally qualified health centers. Thank you.
Thank you so much. Can we remember if there's any questions on this bill? At this time, I'll take a motion to amend due pass. We have a motion from Senator Titus and a second from Senator Stone. Any discussion on the bill? Vice Chair Taylor.
Thank you, Chair. I just want to take a moment to thank Governor List for being fully engaged in this process and being a part of putting the presentation together and making sure we came up with the bill. That was something that's really going to help Nevada. And so, Governor, thank you so much.
Thank you so much. Any other discussion? Moving on to the vote. All those in favor, please say aye. Aye. Any opposed? Motion's carried, and I'll assign that floor statement to Senator Taylor. And Ms. Cooper, Senate Bill 244, please.
Thank you, Chair. Destiny Cooper for the record. Senate Bill 244 requires Medicaid to provide coverage of certain treatments for obesity, sponsored by Senator Lang, etc. It was heard on March 13th. Senate Bill 244 requires the Director of the Department of Health and Human Services to include coverage under Medicaid for certain treatments of obesity and certain programs for diabetes prevention to the extent that federal financial participation is available, amongst other provisions, and there are no amendments to this measure. Thank you.
Thank you so much. This is a due pass motion, but do we have any questions first from committee members? At this time, I'll go ahead and take a motion on due pass of this bill. We have one from Vice Chair Taylor. Do I have a second? Second from Senator Lang. Any discussion? Senator Titus.
Yeah, thank you. I have some concerns about some of these drugs in children and worried about as the medical environment changes and what care is appropriate for youth in particular. I'm worried about any mandates of coverage. I trust that this is going to go through a review process through Medicaid, however, and it still has some hurdles to go through. So I'll be a yes to get this out of the committee, but may change as things progress.
Any other comments? Senator Stone.
Thank you, Mr. Chair. I regret that I'm going to be a no vote on this again because of these newer drugs and the studies in children and I know we're not a fiscal committee, but the high price tag associated with this. So I'm going to be a no for now, but I reserve the right to change my vote when we come to the floor.
Thank you so much. Vice Chair Taylor, we're going to say something?
Yes, thank you, Chair. I just wanted to say I move this because I like what it does. There is a little more information that I reserve my right to change if necessary. I'm not sure that will be the case, but I wanted to go on record.
Thank you so much. Anything else? This one is a due pass, and we already did the motion, and so all those in favor, please say aye. Aye. Any against? We have one nay from Senator Stone. The motion's carried, and I will go ahead and assign that floor statement to Senator Lang. We have completed the work session for today, and so now we will go ahead and move on to the bill presentations. And so at this time, I'm going to go ahead and invite Senator Cruzina to join us, and I'll open the bill hearing on Senate Bill 348. This bill revises provisions relating to healthcare, and you may begin.
Thank you so much, Chair Donyate, Vice Chair Taylor, Senator Lang. You've seen a lot of me today, and all of the members of the committee and our staff. For the record, my name is Julie Pizzina, representing Senate District 12 in Clark County, and I'm presenting Senate Bill 348, which makes revisions relating to health care. I have with me today Annette Logan Parker, founder and chief advocacy and innovation officer of Cure for the Kids Foundation. And I'm going to hand it over to her to share some background on the bill, and then I'll briefly walk through the sections. Thank you.
Thank you, Senator Pazina. My name is Annette Logan Parker, ANNETTELOGAN-PARKER. I am the founder of Cure for the Kids Foundation, and I'm also the chair of the Nevada Rare Disease Advisory Council. I have attended over 200 funerals for Nevada's children, and that's not something I say lightly. I carry their stories with me every day, and I can't help but wonder how many of them might still be here if they had been diagnosed sooner. Senate Bill 348 gives us the tools to act earlier, save lives, and prevent the kind of heartbreak that happens far too often when life-threatening conditions in children are detected too late. Thank you for the opportunity to present this legislation, which modernizes Nevada's newborn screening program in 4 critical ways. First, it ensures Nevada automatically adopts all federally recommended conditions listed on the recommended uniform screening panel, keeping our state aligned with national best practices. 2, it updates Nevada's newborn screening fee to a sustainable amount with modest inflation-based adjustments to ensure the program can keep pace with rising costs and evolving technology. It also strengthens our statewide infrastructure, ensuring newborns who screen positive receive timely in-state follow-up care, including access to genetic services. And lastly, it establishes licensure for genetic counselors so families have access to qualified, compassionate professionals at a time when clear guidance matters most. I want to take a moment to acknowledge the important work being led by Senator Lang through Senate Bill 189 that also addresses licensure of genetic counselors. These 2 bills share the same goal, and we support aligning the language of those 2 bills. It is important to understand that SB 348 is not about starting something new. It's about bringing Nevada in line with national standards. At Cure for the Kids Foundation, we care for children across the state and the surrounding region. Many of them arrive at our clinic after months or even years of unexplained symptoms and no diagnosis. Families often tell us they've seen several doctors before finally being referred to us. And tragically, we've seen too many children whose conditions could have been treated far more effectively if they had been identified at birth. Newborn screening is widely recognized as one of the most effective and cost-saving public health strategies, and the CDC ranks it among the top 10 public health achievements of the 20th century. It's fast, it's non-invasive, and performed within 48 hours of birth. It detects life-threatening yet completely treatable conditions. It saves more than 13,000 lives annually in the United States. This legislation has the power to prevent heartbreaking delays in care for dozens of Nevada families. These are newborns who, under today's limited screening panel, may go months or even years without a diagnosis, missing the critical window when early intervention has all of the opportunity to change things in a significant way. When even one child falls through the cracks, the consequences can be lifelong. Multiply that across our state, the impact both personally and financially is staggering. From a fiscal standpoint, the return on investment is undeniable. By identifying just a few additional cases through expanded screening, Nevada stands to save millions of dollars every year, not only through fewer NICU stays, reduced emergency interventions, but also through a lower demand for long-term medical and disability services for these infants. Every year, Nevada misses the chance to save lives and millions of dollars. Not because we lack the science or the treatment, but because our system hasn't kept up. There is recoverable revenue to be found in smart public health strategies, and newborn screening is one of the clearest examples we have. When we catch conditions early, we avoid costly crisis care, and prevent prolonged hospitalizations, and dramatically reduce reliance on lifelong support services. We're not asking for a blank check. We're offering a substantial return, a return measured not only in dollars saved, but lives changed. This has the power of preventative public health done right, and that's the promise of this legislation. We also cannot overstate the importance of the Nevada State Public Health Laboratory in this effort. They're the only lab authorized to process newborn screening samples in the state of Nevada. This legislation ensures it remains aligned with national standards and has the support needed to expand its capacity and modernize equipment. I want to be extremely clear about the newborn screening fee. It's not a new fee or a tax. The proposed increase of $69 per live birth is a simple adjustment to an existing charge that has remained unchanged for over a decade, despite rising healthcare costs and expanded testing capabilities. It's fully covered by insurance, and more importantly, it is not billed separately to families. It remains embedded in the hospital's global labor and delivery reimbursement rate. While Nevada's newborn screening fee has remained among the lowest in the country, our reimbursement rates for labor and delivery have steadily increased. Hospital fees for childbirth-related costs have risen in the last decade, though the newborn screening fee has not. Updating the screening fee simply aligns it with the economic reality the rest of the system has already recognized. Even with the long overdue adjustment, Nevada will continue to have one of the lowest newborn screening rates in the country. This modest increase ensures the program is sustainable, responsive, and aligned with national standards. This bill also prioritizes keeping families in Nevada by expanding access to clinical genetic services. It includes language to support genetic counselor licensure and provides essential resources to grow the specialized medical genetics program at Cure for the Kids Foundation. By investing in local infrastructure and expertise, we help ensure families receive timely, accurate diagnoses and counseling when they need it the most. This not only improves outcomes, but also significantly reduces healthcare spending. On average, out-of-state care for genetic services can cost Nevada between $15,000 and $25,000 per patient annually when factoring in medical expenses, travel, and lost productivity. By localizing care, the state can save resources while keeping families closer to home during some of the most difficult moments of their lives. Early detection also relieves pressure on our overstretched healthcare workforce. In a state facing serious pediatric and pediatric specialist shortages, preventing advanced illnesses through early screening means fewer emergency room visits, shorter NICU stays, and less strain on care teams. It helps Nevada make the most of the resources that we do have by acting early rather than reacting too late. The benefits of newborn screening extend well beyond healthcare. Misdiagnoses often lead to greater reliance on special education programs, behavioral interventions, and long-term disability services. When conditions are caught early, we give children a better chance at school, and we also reduce the burden on school districts and Medicaid-supported services. This bill is a win for every sector that touches a child's life. And importantly, newborn screening is not a partisan issue. It's one of the rare policies that bring legislators together because it saves lives, lowers costs, and represents the kind of thoughtful, proactive government that we all want to see. I've walked beside families navigating the most unimaginable circumstances. Parents who have exhausted every resource, seen a dozen doctors, and still had no answers. And I've also seen the power of early diagnosis, the relief it brings, the hope it restores, and the outcomes that are only possible when we catch a life-threatening condition in time. I started today by telling you I've attended over 200 funerals for Nevada's children. And I'll end by telling you this. I know without question some of those children would still be here today if their conditions had been diagnosed earlier. Before I close, I'd like to share a powerful statement from the written letter of support submitted by the Southern Nevada Health District, the largest public health authority in the state serving more than 2 million Nevadans. And I quote, "We recognize that early detection and prevention are crucial for improving health outcomes and reducing long-term costs. Newborn screening is one of the most effective public health measures available. It's quick, safe, and can detect a wide range of serious yet treatable conditions within days of birth, often before symptoms emerge." End quote. Senate Bill 348 is a life-saving bill with a cost-saving return. And on behalf of the families we serve today and the thousands of babies yet to be born in Nevada, I respectfully urge your support. Thank you.
Thank you so much. And recognizing time is of the essence and probably presentation times are limited, I'm happy to skip going through a review of the bill because I believe everyone's already read it. I would just say that the reason I felt like this bill was so important and that I worked with Ms. Logan Parker was I had the opportunity in 2019 to work alongside previous senator who was just announced to the Hall of Fame today, Joyce Woodhouse, on Senate Bill 315, which created the Rare Disease Advisory Council. And that was brought about by a constituent of mine now, formerly a constituent of Joyce Woodhouse's, who lost a son at the age of 6 years old to undiagnosed childhood cancer within 48 hours of diagnosis. So the importance of early diagnosis can't be emphasized enough, and that's why this bill is so important and why I'm so happy we're able to bring it today.
Thank you so much. Committee members, any questions? Senator Titus?
Thank you, Mr. Chair. Appreciate you bringing the bill forward and appreciate your engagement. I have a number of questions. First, I've been on the HHC committee in both houses now, and we've certainly have expanded the list of tests that we do on our the newborn screening and all of those things. I don't see anywhere in the bill that expands the tests that we are doing.
Annette Logan Parker for the record. What we're referencing is keeping Nevada's newborn screening panel consistent with the federally recommended universal screening panel. Right now, Nevada does not meet all of the conditions listed on that panel.
Right. So, for clarity, then, if I might continue, Mr. Chair, then if we adopted this and if Nevada doesn't do it already, it would mandate that they increase the number of tests that we are currently doing?
Correct.
And is the state lab prepared to do that with the current machines that they have?
Annette Logan Parker for the record. No, part of this bill includes resources to expand the laboratory capabilities.
And then, so the increase, if I might, sorry. So you said it's just a modest increase, but in reality, it's almost 100%, not quite, because the current fee is, you said it's going to increase to by $69 up to $150. So that's not just a modest increase in fees, that's a dramatic increase in fees. And when you mention that the patients won't have to pay for it, somebody pays for it. And so you said it's included in the global rate. So one of the problems is on global rates, when you get reimbursed as a provider, you get reimbursed for a delivery. Okay, now, so they give you X amount of dollars globally for that delivery, but now there's charges for that delivery. So they don't reimburse you for sutures that you might need, episiotomies and all of blood transfusion, even if they bleed, all of those things they don't reimburse you for because it's a global rate. And now you're adding to that an additional fee. Is that clear? Is that?
Annette Logan Parker for the record. Yes, so the hospital would be responsible for the difference.
Correct. So the hospital then, that's what I'm getting at. Even though you said, oh yeah, no, it's not a big fee and nobody pays for it, somebody pays for it. And so again, that's where some of the costs come. I know we're not a money committee, but that's just part of that, the reality with these things. And one more question. A lot of this, you're changing, you're putting a genetic counselor in the definition of healthcare provider. I certainly believe in genetic counselors. Literally just 3 months ago, I lost a great nephew. He was 3 months old. No history, no problems. My niece had a baby a week late, and then he was perfect, went home for a week, and then suddenly couldn't breathe and had a rare, very rare genetic disorder, no surfactant, couldn't breathe. He just died recently after they did all they could for 3 months. There was no test that could have predicted this. So these tragedies happen to families across the board, across the world, frankly. But I worry that, and there wouldn't have been anybody, and I know you're passionate and you've been in this realm and you've seen things that you've diagnosed or if they could have diagnosed. But again, a genetic counselor can just offer information to parents, assuming they have these tests. And for me, it's an information as opposed to somebody who is actually a healthcare provider. And so I just, putting the genetic counselor now under the definition of a healthcare provider has me somewhat concerned, because they're a provider of information, and perhaps in the long run that's healthcare ultimately, but for me it's just a stretch of the definition of a healthcare provider. It's more of a purveyor of information than a healthcare provider. So that's just something I have a concern. I didn't know if other states have them included in their definition of healthcare provider, and can you tell me how many states, and is that
Annette
consensus?
Logan Parker for the record. I don't have the exact statistics available for you right now, but I'm happy to follow up with you. There are several states. I just don't know the exact number of states.
34.
Oh, thank you. Okay, 34 states. Appreciate that, Chair Dunyate.
And then if I might continue. So if they're designated as healthcare providers,
I
then,
also want to say I'm so sorry for your loss.
I appreciate that. And if they're designated as a healthcare provider, then is that something then Medicaid they could charge? Will they be given a NPI number, and then they will charge for their services and be reimbursed through the Medicaid office or insurances?
Yes.
And so these other states where they exist, they're currently reimbursed,
Many of them are.
but some are, but not. You don't know that they all are.
I don't know that they all are.
Okay, I'm just wondering about premiums, rates, cost. And again, we're not financial, but the reality of this, decisions we make here will ultimately end up over in my committee anyway. So anyway, I appreciate all the questions, and I appreciate you bringing the bill forward.
Thank you. And then just really quickly, it's my understanding the rationale as to why you're looking to get them licensed is because there is a level of credibility in terms of them having to get their master's degrees and so forth, but there's nothing in state law right now prohibiting someone to say they're a genetic counselor, and then there's no reporting requirements in terms of, hey, this person is not authorized to actually be giving this advice because either they're not qualified or they're giving the wrongful advice. So this bill would establish the pathway to do that, right?
Annette Logan Parker for the record. Correct.
Got it. Okay. Any other questions? Senator Lang.
Genetic counselors, currently there's no licensure for counselors, and I think, just to clarify for your bill, you want to get them licensed because then they can bill the insurance for their services. Is that correct?
That is correct.
Any other questions? I know we're not a money committee, but I just wanted to know the intention because it obviously deals with the policy of it. The state health laboratory to stand up the construction of expanded laboratory space. Didn't we already give them funding to do this? Like, aren't they already opening? Like, didn't they just open a new facility, or they're about to open a facility? Like, that's why I'm wondering: is this for Southern Nevada, or like, what's the purpose of that?
Annette Logan Parker for the record. The purpose is to expand the current laboratory even more than it already has expanded. A lot of the resources are for the laboratory equipment itself and then the space required to house that laboratory equipment.
But that would be in Northern Nevada or in Southern Nevada?
Northern Nevada.
Got it. I'm just saying we should probably look at building facilities down south. Just saying. Any other questions? All right, let's go up to open testimony. So, because we are limited for time this evening or this afternoon, we are going to be doing 15, 15, 15 like last meeting. So 15 in support, 15 in opposition, and 15 neutral. We still have the 2 limit capacity, so we just ask folks to be brief in their remarks so as many people can participate. So we'll go ahead and begin testimony in support of this bill. So if you're in support, please come forward in Carson City and in Southern Nevada. And if you give me 1 second, I'm trying to look for my phone so I can start timing. Go for it.
Chair and members of the committee, I'm here today in strong support of Senate Bill 348. My name is Craig Vincey, for the record. Last name is Vincze. I'm the founder of the Max Vincey Foundation, but I'm also the father who lost his son to a rare cancer. In 2021, my 22-year-old son Max died 90 days after diagnosis from a cancer called nut carcinoma. This is an aggressive cancer that strikes predominantly in young people. And those 90 days revealed not only the devastation of his diagnosis for him and our family, but also the fragmented system of care for rare diseases in Nevada. SB 348 creates a critical pathway for faster and more accurate diagnoses by integrating genetic expertise into our local care system. For aggressive cancer like my son's and others that predominantly affect young people, every day is the difference between life and death. And as was previously discussed, this bill modernizes Nevada's newborn screening program. I see the true value lies in building comprehensive infrastructure for rare diseases throughout the entire citizen's lifetime. This is especially vital for adolescent and young adult cancer patients like my son Max. They're actually in a severely underserved category just by virtue of their age. One of the biggest tragedies of Max's journey was the weeks it took to get genetic testing for his tumor. Doctors could not even start treatment because they didn't know what kind of tumor they're dealing with. We waited 3 weeks to get the answer. Now, when you got 90 days to live and you wait 3 weeks for an answer that in other cities and states they're getting in 2 days, we can do better. This bill would strengthen the foundation for improving genetic testing and care. A lot of the same disciplines are needed between the newborn screening and what they need to find tumor genetic information. So I urge you to vote in favor of this, not just for Max's memory, but every Nevada family facing the nightmare of a rare disease diagnosis and those who will. Thank you.
Thank you so much, sir, for sharing your story. We're sorry for your loss. Let's do 2 more in Las Vegas, please.
Good afternoon, Chair and members of the committee. For the record, my name is Dr. Sumit Gupta, SUMITGUPTA. I serve as the current chair of Nevada Newborn Screening Advisory Council, and I practice pediatric hematology oncology here in Las Vegas. I'm here today to speak in strong support of Senate Bill 348, which represents a critical step forward in modernizing Nevada's newborn screening program. Newborn screening is one of the most impactful and cost-effective tools in public health. It allows us to detect serious treatable conditions before symptoms appear, giving children the best possible chance at a healthy start and preventing the need for costly lifelong care. One of the clearest examples of the impact is cystic fibrosis. Before screening, children were often diagnosed only after irreversible damage had occurred. When cystic fibrosis was added to the federal screening panel in 2006, outcomes improved dramatically. But Nevada did not adopt cystic fibrosis screening until 2009, meaning families here missed out on early detection for critical 3 years. Another example is spinal muscular atrophy, in which the children die before their second birthday if they don't get treatment on time. We added this in the screening panel in 2024, being the 49th state in the United States to do so. Senate Bill 348 ensures that won't happen again. This bill allows Nevada to automatically adopt federally recommended screening conditions. It also invests in Nevada State Public Health Lab, supports in-state follow-up care, and updates the long outdated screening fee so we can keep pace with modern standards. Early detection saves lives, and every $1 invested in newborn screening yields an estimated $4 to $10 in saving by preventing costly emergency care, long-term treatment, and social service needs. Senate Bill 348 is a smart, evidence-based investment that is both urgently needed and long overdue. I have also submitted a written letter of support for the record, and I'm happy to answer any follow-up questions the committee may have. Thank you for your time and your commitment to the Nevada's children. Thank you.
Hello, my name is Summer Webb. I'm the mother of a child with infantile onset Pompe disease. I am in support of Bill 348. 2 years ago, my 3-year-old son was hospitalized for a respiratory infection. Although he had been cured of the initial respiratory virus we came in for, something was still wrong. As time went on, he became worse, having to be intubated and placed on life support. All of his organs were in distress as he was in a coma fighting for his life. He lost all muscle tone and became 0 months old. Our smart, beautiful boy lost his ability to talk, walk, hold his head up, eat, and hug and kiss us. The doctors and medical staff exhausted their resources and told us that they could do no more. We needed to fly to Utah and LA for help, is what they told us. We airlifted our son to Utah in the middle of a snowstorm on life support, leaving our minor children at home. We're originally from Los Angeles and have no family here in Vegas. So family members had to alternate coming to our home to watch our kids for 5 months as we went from Utah to UCLA for diagnosis and treatment. I lived in the ICU with my son, never leaving him or seeing my other children for these 5 months. And this was an extreme strain on my family during an already traumatic situation. Nevada is one of the few states that do not screen for Pompe disease on the newborn screening. We found out that our son was born with infantile onset Pompe disease, a lysosomal storage disorder, and there is no cure. His body doesn't produce the enzyme needed to break down the sugar in his body, so it stores and builds in his muscles, causing damage. This means that since birth, the sugar was storing in his muscles, building up and creating damage and scar tissue all around them until they either gave out or almost gave out. His heart was enlarged, his kidneys failing, lungs and on a ventilator, and he could do nothing. Most children with this disorder do not live to be 2 years old. Now my son is receiving life-saving enzyme replacement therapy infusions every week and fighting every day to live, but twice as hard because of all of the irreversible damage that was done before he received treatment. Now, I am originally from California, like I said, and I've been living in Las Vegas for 10 years. I am the VP of a finance company here in Nevada. I am on the executive board of the Women's Chamber of Commerce of Nevada and hold several board positions for charitable organizations and support our community. Although I love living here in Las Vegas and raising my family here, I can't help but having regrets on moving here and having my child here.
Ma'am,
because California does test for Pompe.
If you can please complete your remarks, please.
Yes, sir. They do test for Pompe, so I just know that if I would have had my son in California, he would have been screened at birth and could have prevented irreversible damage that he almost lost his life. So I urge you to pass this because rare diseases, time is everything for them, and early detection can mean the difference between manageable treatment and irreversible damage. You will save lives with Bill 348 and make meaningful differences for families like ours.
If you can please send your comments,
Thank you.
We would greatly appreciate it. Let's go here to Carson City, please.
Thank you.
Good afternoon, Chair and members of the committee. My name's Stephanie Van Hooser, VanHooser. I am the Administrative Director of the Nevada State Public Health Lab. In July 2014, the Nevada State Public Health Lab began conducting newborn screening in state, transitioning from the prior practice of outer-state testing. At implementation, the screening panel included 28 of the 36 core conditions recommended by HRSA through the Recommended Uniform Screening Panel, also known as the RUSP. Since that time, the laboratory has successfully expanded the screening panel to include severe combined immunodeficiency, spinal muscular atrophy, and X-linked adrenoleukodystrophy. All that was supported by funding from HRSA and the American Rescue Plan. Since 2014, the Nevada State Public Health Laboratory has maintained a newborn screening fee of $81 per birth, and that includes both the first and the second screen. This fee is one of the lowest rates in the nation. Currently, 5 core conditions recommended by the RESP have yet to be implemented in Nevada. Establishing a modernized, sustainable fee structure is essential for the Nevada State Public Health Laboratory to maintain its current testing capabilities and expand the state's newborn screening panel in alignment with the RESP. A forward-looking fee model will enable the continued addition of conditions enhancing early detection of treatable, heritable disorders and supporting timely interventions that improve long-term health outcomes and quality of life for affected children. I respectfully urge your support of Senate Bill 348, a critical measure aimed at strengthening Nevada's public health infrastructure and improving health outcomes for the state's newborns and their families. Thank you for your time and thoughtful consideration.
Good afternoon, Chair Donate,
Vice Chair Taylor, and members of the committee. My name is Jacqueline Nguyen, Nguyen, representing the Nevada State Medical Association. We had worked on amendments and supported SB 189, and really appreciate that the language here will be aligned to that. This bill will bring improvement to Nevada's newborn screening program by expanding access to early detection of rare but treatable genetic or metabolic conditions. We know that early intervention can lead to better health outcomes and can reduce long-term healthcare costs, and most importantly, help reduce heartache for patients and their families. Thank you, NSMAs, and support.
Thank you so much. Let's go online. AVH, is there anyone online that would like to testify in support?
Thank you, Chair. If you would like to testify in support of Senate Bill 348, please press *9 now to join the queue.
Hello, my name is Katrin Ivanov, Kaprin Idano Frank, and I urge you to vote for this bill. If you need to make changes and think of out-of-the-box solutions, somebody mentioned maybe build another app in rural Nevada where maybe it's going to be cheaper and it's going to help create jobs there, or cut some other spending like the Christmas bill, where we're giving money to nonprofits, and I love nonprofits. I donate money. I teach my kids to donate time and money to nonprofits, but nonprofits should be financed by private people, not by our tax money. They could have used this money to support bills like this, where it's affecting everybody, regardless of their political views or color or anything. Anything that can be screened and detected early. We all know early detection is very, very important for preventing of death. And unfortunate enough to not be in the situation of the people that are presenting this bill. And I haven't lost a child on something like that. Thank you, Lord. However, I am a parent, and my heart goes out to any parent that loses a child. I don't care what political agenda they have or views. This bill would help everybody. And if they need to cut from other expenses, as their Christmas bill that they passed last time, that were giving each other money, one of the legislators had to leave legislation because she went to work for the nonprofit that they voted $250,000 for, and her salary was $250,000 in that same nonprofit with 3 people working in it, and probably all the money going for salary.
Thank you, ma'am, for your comment. AVH, we only have time for one more, so if we can go on to the next caller, please.
Good afternoon, Chair and members of the committee. My name is Ophelia Genteff, GENTSCHEFF, and I am the statewide newborn screening coordinator at the Nevada State Public Health Lab. Each year, we screen more than 33,000 Nevada newborns for serious but treatable conditions. Our work is time sensitive. Delays of even a few days can result in irreversible damage or missed opportunities for treatment. As the federal government continues to expand the list of recommended screening conditions, we must also expand our capacity. This includes modernizing our equipment, hiring and training more laboratory staff, and maintaining rapid turnaround times for life-saving results. SB 348 directly supports this need. It ensures that Nevada not only adopts all federally recommended screening conditions, but also has the laboratory infrastructure to implement them effectively. Right now, we're at a tipping point. Our laboratory team is dedicated, but we cannot do more with the same resources. SB 348 gives us the tools to keep pace with science and serve families statewide with accuracy, speed, and reliability. I respectfully urge your support for this important bill and for the laboratory capacity that makes newborn screening truly work. Thank you for your time and dedication in promoting public health and the needs of our most vulnerable population.
Thank you so much. That concludes our time allocated for support testimonies. So we will now move on to opposition testimony. For those that didn't get to participate, obviously you can send in your comments in writing to our committee secretary so that way it's reflected on the record. Anyone that is looking to oppose this bill or testify in opposition, we ask for you to please come forward at this time. We don't have anyone here in Carson City, and I don't see anyone in Las Vegas. AVH, is there anyone online?
If you'd like to testify in opposition on SB 348, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in opposition at this time.
Thank you so much. Anyone looking to testify in neutral on this bill, please come forward. Seeing none here or in Las Vegas, AVH, is there anyone online?
Testify in neutral, please press star 9 on your phone to take your place in the queue.
Yes. Hi, my name is Nicola Longo, Nicola Longo, and I am a clinical and biochemical geneticist from UCLA. I've been coming to Nevada, to Las Vegas, to see patients with metabolic disorder for a long time, and I believe it is important that Nevada has the opportunity of finding and hiring their own metabolic geneticists to identify and treat patients with metabolic disorder. These children are identified by newborn screening and need to go out of state. They come to see us at UCLA, or they go to the University of Utah, where I worked until last year, to receive care. I think that there needs to be a provision to allow physicians in Nevada to stay in Nevada and to care for these patients. I hope that with the expansion of this bill, there will be sufficient amount of money for the newborn screening program to accomplish all of the goals that are part of a true program, not just a screening test. Thank you.
Chair, there are no more callers in neutral at this time.
Thank you so much. Seeing no other testimony and seeing that the bill sponsor has no comments, continuing, we're going to go ahead and close this testimony period, and we're going to close the hearing as well. We'll now move on to Senate Bill 349. I'll go ahead and open the hearing on this bill. This bill revises provisions relating to anatomical gifts, and with us, we welcome back Senator Pezzina.
Thanks you so much again, Chair Doñate, Vice Chair Taylor, and the entire committee. Long time no see. For the record, my name is Julie Pezzina, representing Senate District 12 in Clark County, and I am going to introduce my wonderful intern today who's been so hardworking from UNLV, who's going to help present Senate Bill 349, which revises provisions relating to anatomical gifts, and she will work with the Nevada Donor Network and Dan Musgrove on that presentation. Sydney Mitchell's been serving as my legislative intern during the session. She was born and raised in Nevada and is currently a third-year student at UNLV studying political science with a minor in Spanish. Sydney currently aids Brookings Mountain West and the Lindsay Institute with their Data Hub project, a think tank on public policy in the Mountain West region, and comes by her love of education honestly because her dad is a public school teacher in Clark County. And with that, I'm going to hand it over to the very capable Sydney Mitchell.
Thank you, Chair Doñate and members of the committee. For the record, my name is Sydney Mitchell, spelled SYDNEYMITCHELL. I'm presenting Senate Bill 349, which revises provisions relating to anatomical gifts. I'm going to give a small piece of background before I turn it over to Dan Musgrove, but I think there are some important things to note. According to an investigation from the Kaiser Health Foundation, between 2014 and 2019, roughly 170 organs could not be transplanted, and almost 370 were near misses due to delays from transportation issues. With over 113,000 people on waitlists desperately waiting for a life-changing organ, there are many missed opportunities due to transportation wait times. This is something to keep in mind throughout this presentation. And with that, I will now be turning it over to Dan Musgrove.
Thank you, Dan Musgrove, Strategies 360. Today, I'm proudly on behalf of Nevada Donor Network. Thank you, Sydney. Thank you, Senator Pezzina, for allowing me to present to you this bill. I'm going to walk you through the amendment, which really is us changing a couple of portions of the bill in response to work that we've been doing with both the funeral and mortuary folks, as well as the coroners from Clark and Washoe. They are crucial partners to Nevada Donor Network in the work that we do, and it was important for us that they felt comfortable with what we were trying to accomplish. And the idea of transportation of the deceased is a bit, from what I understand, it's a bit silent in NRS, and but because of what we want to do, especially in Southern Nevada and hope to in other areas of the state, we are creating what's called a donor care unit, where, because very frankly, we are at the mercy of hospitals and sometimes the funeral homes for our ability to get those procurement of organs for life-saving transplants. As you may be aware, there is a very finite window of time in which organs are viable. And it's very crucial for us, as Sydney described, for us to make sure we're within those guidelines so that the organs can become viable and be given to for life-saving transplants. And so we wanted to make sure that we're creating this donor care unit, which will be an off-site facility, okay, where normally this happens in a hospital. But as you can imagine, sometimes hospital ORs are very busy, and so we're at their mercy. And sometimes mortuaries and funeral homes are very busy, and we're at their mercy again. And so we wanted the ability to transport to our donor care unit so we can begin that procurement process. So this bill does a couple of things. It allows that the county coordinator may prescribe a procedure allowing for the procurement organization, which is someone like Nevada Donor Network, to transport only within the state of Nevada and arrange for transportation within the state of Nevada to get that body or part for transplantation. And then the second thing that we did was to ensure that we're only going to transport when we need special medical equipment to make sure that the transport is safe and ensures the viability. And that was kind of the second half of our amendment, and that's really it. We appreciate the committee allowing us to bring this forward. It's so crucial that we have this opportunity to, because one person, one organ donor can save the lives of 8 people, and the tissue and other stuff can impact and prolong and help people well beyond that. And so I want to thank the committee for your attention. I'm open for questions, and thank you again.
Thank you so much. Do we have any questions? Senator Ling.
Hi. So as you know, Renown is opening a transplant center, and they're going to do kidneys now and move to livers. I'm just wondering, in this bill, if you have thought ahead about a provision to do this also in Reno.
Thank you, Senator. Okay to go direct. Thank you. Dan Musgrove. It allows for that. It's open enough so it can be done statewide. There is a county coroner in Clark, and there's a county coroner in Washoe County, and we work tremendously well with Dr. Knight. And we at this point don't envision immediately the need to have a donor care unit because most of that will either probably happen in Renown, just because of the sheer volume. Renown will either be able to help us or the other hospitals will be able to help us. But absolutely, if we feel that the need is great enough, then we would create a donor care unit here up in Reno, and then we would work with the Washoe County coroner. And the bill allows for that. Thank you.
Thank you. So my question then is, if the need was there to be able to have this in Reno, how long would it take to set it up?
Good question. I may have to phone a friend on that one. Mr. Tyree Gray, I think, is in the audience in Las Vegas. Maybe not. I will get that information for you. Thank you, Senator Dan Musgrove.
Any other questions? Senator Titus.
Thank you, Mr. Chair. Thank you all for being here, and Mr. Musgrave, I appreciate the conversation we've had, and Senator, I appreciate you bringing stuff forward like this. A number of questions, really. Currently, if you are looking at moving a donor who has been determined no longer living, you're going to be able to transport that body to harvest organs at a different location, or are you looking at just pieces?
Dan Musgrove, we would procure those organs. We would move. That is our. We are in Nevada Donor Network is working right now to build a donor care unit, which would be an off-site facility that essentially has an operating room where our doctors, our staff could then take the deceased and do that procurement of organs. And so, because, like I said earlier, we are sometimes at the mercy of hospitals and using their emergency rooms to do that right now. And they certainly, want to be helpful, but sometimes they need those rooms, and we certainly don't want to miss our window of time.
So you're looking at picking up the donor from a location where they've been declared, and then transporting them to a specific location where you would then harvest whatever there is to harvest, and then you will ask the coroner to come and get give me a process here.
Dan Musgrove, and I think that the funeral folks might be able to add some additional color to that. We would go with whatever the family's wishes are. Normally, at that point, the funeral home will pick up the deceased and begin that normal process of whatever the family's wishes might be.
A follow-up, if I might. So when you have a transport, and I understand that they may be on a ventilator still, and so they're going to have some medical equipment, who will regulate? Will they be subject to the same regulation as the ambulances are, paramedics, those folks who deal with ventilators, who deal with emergency vehicles?
Dan Musgrove, I'd like to get a more advanced answer to you, but my belief, from what I understand, is because the individual is deceased, has been declared dead, there isn't quite that strict regulation that's in place as far as I know. But and so we would have basically a vehicle that has that equipment on it to preserve the viability of the organs. And that's our sole intent of having that medical equipment on there. Because again, the person in the hospital has been declared deceased.
I understand. And then, so if I might follow up. So the attendant in that vehicle, are they going to be a licensed paramedic, or are they going to understand how do you operate an intubation, how you operate perhaps cardiac compressions? What will be, who will be attending, what the license will be, and then liability?
Dan Musgrove, I think we would be assuming the liability at that point, and our staff that deals with these individuals who have willingly, become an organ donor, have all the requisite training and certifications. But I will get you a specific answer as who do we envision in that vehicle that would transport.
And again,
and I imagine that would be done in regulation or by the Southern, whoever at the jurisdiction, and probably not in NRS, but I will get that information for you.
Right. I think there's a whole licensure component to, a transport vehicle, like essentially with medical equipment on board. It's not an ambulance per se. You're moving a body that you're continuing to keep some viability to it, as you testified. And there's a lot of logistics and a lot of pieces to that, literally. And and the concept is great. I understand the problem in my area, rural Nevada. Certainly we always, when I would pronounce somebody, have to contact the donor network and all of the above, and there could be delays, and certainly we want to maximize. If somebody did wish to donate, that could certainly be part of their wishes. And but I am concerned about the logistics and what really has to happen here, although the concept sounds great.
Any other questions? I think mine was answered, but I just wanted to share. I think the concern that I had was more so in terms of what it would take to become a procurement organization and what the requirements and standards are, so that if there is an effort of malfeasance, of they're not transporting correctly, or I know last session we talked about the influence of a black market if there was one, and so I know that's not the case, but I just wanted to see like what were the reporting requirements if there was a sign of negligence, and I think that's what Senator Titus was kind of hinting at, right? Like, how do you go after for someone that makes an error or so forth? Is it the technician themselves? Is it the entity? Is it the organization? And I believe, from my understanding, is that you have the CMS designation, and so it would be CMS that would essentially revocate your license to practice. So I don't know, Mr. Musgrove, if you want to take a stab at it.
Dan Musgrove, you hit it on the head. It's CMS. There's 56 designated OPOs, organ procurement organizations, across the country, and they have to meet a very high level of standards to be considered one of those OPOs.
Yeah, the only thing that I would recommend in the amendment, just to tighten it, is perhaps in the regulations that the coroner's office would prescribe some issuance of revocation as well at the local level if they notice complaints, et cetera, so that we don't have to wait for CMS, because sometimes we know the magnitude of CMS and it's a little bit longer and delayed and so forth. So I'm just saying that more of a longer term thing. So
thank you, Senator.
Any other questions? Let's open it up for support testimony. If you would like to provide support testimony, we ask for folks to come forward here in Carson and in Southern Nevada. Give me 1 second. Mr. Hardy, you may begin.
Thank you, Chair, members of the committee. Warren Hardy, today representing La Paloma Funeral Services and Life Science Anatomical. We do appreciate our partnership with the Nevada Donor Network. They are our organ procurement organization in Nevada, and we're grateful to have them, and we're grateful for the work they do. We're also grateful to the chair, or the sponsor of the bill, for her willingness to hear our concerns. I'm encouraged by the conversation that's occurred before the committee, because this is an area that there aren't a lot of direction and protections on, and we need them. And so we get very concerned. We were very concerned, obviously, because most of the protections that do exist in the state reside with the funeral directors and the funeral homes that are traditionally the ones that pick up these decedents. What Nevada Donor Network and Senator Pezzina has identified here is a need, and I think Sydney did a wonderful job of really drilling down on that need. There's a few of these where it actually requires medical equipment to be able to protect the viability of the organ, and we're not interested in taking on that liability or investing in the equipment necessary to do it. So the language is drafted is fantastic for us. We appreciate it. Again, we appreciate the sponsors and the proponents working with us on this bill. We're very happy with the product. Thank you.
Good afternoon, Chair Daniate and members of the committee. For the record, my name is Taylor Avery, and I'm the Manager of Political Affairs for the Vegas Chamber. The Chamber is in support of SB 349. We appreciate the bill's intent to allow procurement organizations, which effectively operate as the middleman, to transport anatomical gifts to facilitate effective and speedy organ donations. This ensures that a donor's last wishes are honored and precious anatomical gifts don't go to waste. We'd like to thank Senator Pezzina for bringing the bill, and thank you to the committee for your consideration.
Mr. Chair, members of the committee, my name is Mark Fiorentino. I'm with the law firm of Kemper Kroll. We represent the Davis Funeral Home, and I will say mostly ditto to Senator Hardy's testimony. We're very grateful to Senator Pezzina for working with us and the other stakeholders to get this in a position where it's at, and we're supportive. Thank you very much.
Thank you, Chair and members of the committee. Blaine Osborne, Nevada Rural Hospital Partners. For the record, I am also, in full disclosure, a board member of the Nevada Donor Network. I think this is a very good bill and happy to be here in support. Thank you.
Thank you, Chair and members of the committee. Allison Herzik, Director of Government Relations for Dignity Health St. Rose Dominican, and we are in support. Thank you.
Good afternoon. My name is Patrick Kelly with the Nevada Hospital Association, and we support organ procurement efforts. Thank you.
Thank you so much. Anyone else here in Carson City? Seeing none here in Las Vegas AVH, is there anyone online?
To testify in support, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in support at this time.
Thank you so much. Let's move on to testimony in opposition. If there's anyone here in Carson, I don't see anyone here or in Las Vegas. AVH, is there anyone online?
Testify in opposition, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in opposition.
Thank you so much. Moving on to neutral testimony. Is there anyone that would like to testify in neutral on this bill? Please come forward. Ms. Jacobs, you may proceed.
Good afternoon, Chair Giannate, members of the committee, Joanna Jacob, JACOB, on behalf of Clark County. I'm here today in a neutral position. Heading in here, I want to thank Mr. Musgrove and Senator Pizzina. The amendment that was before you referencing coroners was something that we did work on with the bill proponents. And what we really envisioned with that, and after the discussion today, might need some more work from what we heard from the committee. We envision that would be a process whereby we would ensure that the coroner would be notified if there was a transport, particularly if there's an investigation that is ongoing, and that was kind of our intent there. We certainly will continue to work with the Nevada Donor Network, and we have, as we did last session, and we have traditionally done so to tighten up the language, and we'll hopefully bring it back to you for consideration for work session. Thank you very much.
Good afternoon, Chair Giannate, members of the committee. For the record, Cadence Matievich, CADENCEMATIJEVICH, representing Washoe County. I will ditto the comments from Ms. Jacob, but also say, Mr. Chairman, I don't think we envisioned that coroners would be establishing regulations that had to do with the actual procurement. I think that's a little outside of the scope of what they do, and so we look forward to working with Senator Pizzina on that, and perhaps there might be another entity that's more appropriate to establish those regulations. We're not sure that it's the medical examiner and coroner. Thank you.
Thank you so much. Anyone else here? AVH, is there anyone else online?
If you'd like to testify in neutral, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in neutral at this time.
Thank you so much. I don't know if the bill sponsor has any closing remarks. Quickly.
I will, Mr. Chair. Dan Musgrove, and I did it because you opened the door on SB 109 from last session. I just wanted to thank this committee because SB 109 has saved, because of the work that you made us do on that bill, 20 people have qualified under the SB 109 provisions. 80 lives have been saved. And here's a story that an unintended wonderful consequence. A young 15-year-old got into an argument with his parents and left his house on his bicycle and had no ID, no identification, no cell phone, and was tragically hit in a car accident. And they could not identify him. But because of SB 109, we went through a laborious process of trying to find out who he might be related to. We found his mother and father, and she had the chance to say goodbye to her son in the hospital rather than in the coroner's office. And that's the impact of the legislation that you do on a daily basis. Thank you.
Thank you so much. We're going to go ahead and close the hearing on this bill and move on to the next one. So I'll go ahead and open the bill hearings for Senate Bill 337. This bill revises provisions. Oh, hold on. Got the wrong one.
337. Yeah, 337.
This bill revises provisions relating to opioids, and so I'll invite Senator Lang to begin the presentation when she's ready.
Thank you, Chair Donate. Committee members, my name is Roberta Lang, representing Senate District 7 in Clark County. Today I'm presenting Senate Bill 337, which revises provisions related to opioids. I will have my experts speak to you, then I will go over the sections of the bill because it's a lengthy bill and I think that's probably a really good thing to do. And then we'll play a little bit of musical chairs and bring up some other people. So this is Lisa Mead, and this is her son Matt. And
Jared.
so,
Jared.
Oh, Jared? Somebody told me that.
We'll stay with Matt.
Jared. Okay, here we go.
Thank you, Chair and committee members. My name is Lisa Mead, M-E-A-D, and I am a proud Nevadan and here as both a mother and the CEO of Reno Orthopedic Clinic. I have dedicated 40 years to healthcare administration in hospitals, medical schools, and private practice. And in that time, I have witnessed firsthand both the power and the peril of pain management. Opioids were once the gold standard for post-surgical pain relief. Surgeons, including the 35 I work for, were trained to use them as a primary tool, but we have also seen the unintended consequences. Patients who once came to us seeking relief from pain have instead found themselves trapped in a cycle of dependence. I have seen it professionally in the patients we serve, and I have experienced the devastation of opioid addiction after a legal prescription within my own family. Even with my direct knowledge and access, that led us to one of the best and only physicians in the world performing a rare procedure at one of the most prestigious facilities in the world. I could not predict, prevent, or fix my son's subsequent addiction to opioids. A miraculous surgery that restored the use of his arm took away 7 years of his life. Can you imagine what it must be like for those seeking treatment, armed only with a hope to relieve their pain, and little to no education to make a choice of how that pain is relieved? We can both relieve pain and prevent addiction by removing barriers addressed in this bill. 70% of those addicted to opioids start with a legal prescription, often after a surgical procedure. If this entire committee went into surgery, where opioids were prescribed, and you use those opioids for more than 5 days, at least one of you would have a 50% chance of becoming addicted. Yes, it only takes 5 days for addiction to take hold, as recent studies have shown. It's like a game of Russian roulette. There is no way to know who gets that devastating bullet. We must do better. There are many tools in the pain management tool chest. Some are combinations of readily available non-addictive drugs and therapies. Even more promising are several new non-addictive drugs that are proving to be highly effective in managing pain, but unfortunately come with a very high price tag to either the facility or the patient. The new FDA-approved sodium channel blockers are not yet covered by insurance, and patients are charged $15 per pill. By comparison, a 10-day prescription for hydrocodone will cost most insureds less than $5 for the entire prescription. One of the most critical pieces of this legislation is coverage for non-addictive medications by insurers operating in our state to give doctors and patients choices that are affordable and safe. It's why we at Reno Orthopedic Center have made it our mission to do our part to prevent a possibly devastating outcome from surgery like my son's. A few months ago, we became the first ambulatory surgery center in the state of Nevada certified to give patients the option to choose to have their surgery opioid-free or opioid-sparing. We were lucky enough to be connected with Dr. Matt McCord, who is doing this work in Michigan. He set us on the course, giving our doctors the tools to offer this option. We call it OSCAR, Opioid-Sparing Care and Recovery. Our very first OSCAR patient came to one of our surgeons after suffering hip pain for 7 years, avoiding surgery because of the debilitating effects of opioids she had experienced in a previous medical issue. She was unable to work, exercise, travel, or enjoy life because of her very treatable hip pain. Conservative treatment had failed, so she suffered because she didn't think she had a choice. Patients can avoid necessary procedures, living in pain for years, not out of fear of surgery itself, but out of the fear that what the medications they would need afterward could do to them. That should never be the case. Some suffered debilitating side effects, some had witnessed the addiction of a family or friend, and some have beat addiction and need a safe place to have surgery where they won't risk a relapse. We need to give them that place. More importantly, we need to support doctors with education and implore facilities to find a better way so that there are no more preventable tragedies in our state. SB 337 is a step forward in ensuring that patients and providers alike have access to better, safer pain management solutions. It's about giving people a choice for effective pain relief without the risk of addiction, a choice for a future where surgery is no longer a fear of dependency. Nevada has that opportunity to lead in this effort. We can show the country that innovation in pain management is not just possible, it's happening right here. So I urge you to support this bill and stand with us in this critical fight against the opioid crisis.
Hello, good afternoon, Chair and members of the committee. My name is Jared Davis. Jared is spelled G-E-R-A-D, Davis, D-A-V-I-S. And I stand before you today, not just as a citizen of Nevada, but someone whose life was profoundly altered by a single prescription. I'm also speaking to you as a certified alcohol and drug counselor who works on the front lines of the battle against addiction and witnesses firsthand the devastating consequences of opioid dependency every single day. In 2011, I was involved in a serious motorcycle accident that shattered my jaw and left my right arm paralyzed after I collided with a tree. The physical pain was unimaginable, and to manage it, I was prescribed a high-powered opiate, a decision that would unknowingly change the course of my life. At the time, I was unaware of the addictive nature of these medications or the brutal withdrawal symptoms that would follow. No one told me that my treatment for pain could lead to years of suffering, addiction, and loss. What started as a doctor-approved pain management tactic turned into a 7-year battle with addiction, one that led to multiple failed attempts at sobriety, the dismantling of relationships with my family, friends, and community, and the loss of nearly everything I had worked for. The very medication meant to help me recover ultimately took away my ability to function as a productive member of society. But my story is not unique. Unfortunately, this problem touches millions of lives, not just the individuals who suffer from addiction, but also the families who endure the pain of watching their loved ones struggle, lose hope, and spiral into a cycle of dependency they never saw coming. And today, the crisis is worse than ever. As a counselor, I continue to see the devastating effects of opioids, which has now evolved into something far deadlier, fentanyl. What started as an epidemic of prescription opioid addiction has morphed into a full-scale public health emergency. Fentanyl is now the leading cause of overdoses in this country. It is 50 times more potent than heroin and is increasingly found laced in counterfeit pills and street drugs, putting even casual or first-time users at an extreme risk of fatal overdose. I work with people every day who, like me, started with a legitimate prescription but ended up losing everything. Many of them never intended to become addicted. They simply followed their doctor's orders. But once that prescription ran out, their bodies craved more. Some turned to illegal opioids. Others unknowingly used substances laced with fentanyl. The result, lives lost too soon, families destroyed, and communities left reeling. This is why Senate Bill 337 is so critical. This bill introduces something I desperately wish I had back then, the choice for opioid-free surgery and a comprehensive patient education about the risks of opioids. Had I been informed of an alternative pain management option, had I been given the chance to make a different choice, I could have spared myself the devastating consequences that followed. Senate Bill 337 ensures that future patients will have that choice. We are in the midst of a national opioid crisis, one that in many cases begin with well-intended prescriptions. Nevada has the opportunity to be the leader in preventing addiction before it starts by ensuring that patients receive clear, transparent, and informed options when it comes to post-surgical pain management. By passing this bill, you are not just changing policy, you are changing lives. You are giving people like me a chance to avoid addiction before it ever begins. You are giving families the ability to keep their loved ones safe, and you are protecting the communities from the ripple effects of opioid dependency. I urge you to support this bill, not just for me, but for the thousands of Nevadans who deserve a future free from opioid dependency. Thank you for your time.
Thank you for that. Just to do a little editorial, the on CNN, they did a huge documentary on the opioid crisis in the United States. And if you haven't seen it, it's worth your time. It will knock your socks off with what they say and what happened. And it has changed how I think about this, which is why I wanted to do this bill so much, because I think we have to make changes in our society and positive changes in an opioid-free alternative. So before I walk through the sections of the bill, I'd like to pass it over to Dr. Sanju Joseph from Las Vegas to give a bit of background and explain how this bill was brought about.
Thank you, Senators. My name is Sanju Joseph. I'm a board-certified general surgeon and surgical oncologist. I spent my career in academic surgery and moved here in 2017. In my academic practice, I've trained surgery residents, medical students, conducted research, and I continuously tackle some of the most complex surgical cases. When I moved here to start the general surgery residency program at Valley Health System. So have been involved with that program up until I founded my own practice, Summit Specialty Physicians, in 2022. There I focused on providing opioid-free and opening-sparing surgical techniques. Because of my past academic practice and watching this crisis occur in front of me, I felt this was a very important pivot that I needed to make. Since that time, I've had phenomenal results. I'm proud to say I've presented my own outcomes research of over 250 opioid-free surgeries, specifically hernia surgeries under working and caring for labor employees. I presented at the National Alliance of Healthcare Payers as well as at a major surgical conference. In that experience, of the 250 patients that I've operated on, only 4 patients took opioids at all, and only 1 of them took it for more than 4 days, and they took it for 5. More importantly, and the reason this became important to the payer side, is I was able to get all of those patients back to work within 4.5 weeks, compared to the standard, which was 12 weeks. And for people like the Anheuser-Busch distributors, United Auto Workers, labor union employees, this is a major financial impact for them. The reason I got turned on and to this and was very interested in supporting Senate Bill 337 is because it is important to recognize the opioid crisis on multiple levels. One is very important, and that is taking care of the addicted patient who's actively overdosing. I don't think anyone in healthcare would disagree that that is an important thing to do and to save lives. However, I also will tell you that I'm very focused on what I call turning off the faucet. Taking care of a patient that's overdosing is mopping the floor. Until we turn off the faucet and stop these addictions from occurring, we are not helping this community. It is important to recognize that we have lost 1 million working Americans to an opioid overdose. We lose 1.4 million workers from the workforce. If you look at labor jobs, 25% of the people working are chronically addicted to opioids. If you go to the United Auto Workers and look at the people working on the line building our cars, that number goes up to 30%. Of the patients who are addicted in that subset, 60%, their sentinel event is a surgical one. Either shoulder surgery, orthopedics, general surgery, accidents. They start their addiction through a doctor that is trying to do their best. And I am not faulting the doctors. I see patients who need these medicines. It is important. But most of them, if you give them an alternative, they will jump at it because they want to get back to work. This is an important step, and this is a state that needs it. Today, the economic impact, last set of data showed it was a $1.5 trillion problem in 2020. 37% increase from 2017. Addictions have only increased even though we recognize as a healthcare community what these problems lie. and where they are going. The problem is multifold. The moment someone becomes addicted, we all know what happens. It becomes a problem that falls onto our state. They begin absenteeism at work. They are more likely to be admitted to a hospital. They will lose their jobs. They will end up on state Medicaid, on state aid programs, and ultimately being homeless, and they have overwhelmed our criminal justice system. I want to reemphasize the most important point that I feel. You will hear a lot about treatment and prevention, and I draw a very important line between prevention of death and prevention of an overdose and prevention of the addiction starting. Senate Bill 337 focuses on the prevention of the addiction ever starting. It is important for us to do, and I hope that this bill will make Nevada the gold standard in addressing the opioid crisis. Thank you.
Thank you so much. Chair, I'll go through the sections of the bill real quickly, if that's okay.
Senator Lang, we have reached the 15-minute mark, so maybe if we just can, are you comfortable just going straight to questions?
Well, we have a couple of proposed amendments, and I think it'll make the questions go better.
for it.
Maybe I can tell you
Yeah,
those.
go for it. Yep.
Okay. We have met with the nurses, and the nurses, there's a couple places in the bill in section 36 that talks about nurses and their role in this. In Nevada, nurses can't do the kinds of things that are in the bill, so we're going to be amending that out. The second thing is NJA. The attorneys have talked to us about the immunity clause that we have in the bill. It's in section 21. And because we negotiated that in last session and they have a 10-year agreement, we're going to update that and change it to NRS 41A.045, and they've agreed to that. We've also met with the hospitals, and the hospitals have told us that they need time to implement this, and they've asked us to move the start date back. So we've moved the start date back to July 1st, 2026 to allow them to get things in order, and also the insurance companies. We continue to meet with stakeholders, and hopefully we will be able to, before work session, bring you back the amendments so we can move forward. Thank you. And Chair, I think we have someone on Zoom to answer questions as well. I think we have some Matt McCord on Zoom. This bill passed in the state of Michigan unanimously by both parties. So Matt will be able to get some information background if you need it.
Sounds good. Thank you so much. Let's go to questions. Senator Titus.
We're going to go sit on the chairs.
Thank you, Mr. Chair, and that's exactly where I was going. So my question really is, what other states have already passed this, and what kind of outcome data do they have to share that it made a difference with the opiate overdoses?
I think Michigan was I believe the eighth or ninth state to have passed this legislation. Some of the other states you can imagine, West Virginia and others. Honestly, we actually in Michigan passed this in 2018. In 2022, we actually added more teeth to the legislation to make it more meaningful and transparent for employers. And we're now just seeing the benefits of that. So the Nevada law incorporates most of those changes that we thought were important to enhance adoption. So it's still early days on that for the state of Michigan.
So if I might follow up with that. So you said you started it in Michigan in 2018, and did you not see any improvement? So you changed your law or made additional changes to it that are what we are seeing in the Nevada proposal?
Yes, yeah. For example, we recommended that it be included in with the open enrollment health insurance paperwork in the state of Michigan for companies that are domiciled in the state of Michigan. That helped make it more apparent for those employees, so they knew that they actually were empowered now to have this advanced directive, so they can at least put a stake in the ground and ask providers to provide the information they need to make more informed decisions on whether they receive opioids for acute pain.
And I'm sorry, sir, just for clarification, you're saying that since you changed it in 2021, you're seeing better outcomes. Does that mean you're seeing less overdoses or an addiction, or you're seeing more compliance?
Still yet to be measured, I have to emphasize, and because these are mostly with large union partners that we're doing this with, and they keep some of that information to themselves, but they have a significant opioid problem, and I wasn't able to make a presentation, but I will say that this, our problem, let's be clear here, we don't have a pain crisis in America. We have an overprescribing crisis, and we're addressing that with this legislation.
Well, I think I just am anxious, and maybe Senator Lang, you have somebody, because I know I've sat in this building for 6 sessions now, and every session we have more regulations on providers and overprescribing, and I've seen data that truly providers have prescribed less, that we now have multiple layers of mandates that we are required to sign an agreement with the patient before I prescribe narcotics, and I have to sign on to the physician, whatever it's called, periodically to make sure that this person's not seeking drugs, that they're not getting an amount of prescription. I'm reviewed on what I prescribe, and so we have all these protections in place in Nevada, but yet our overdoses continue to rise based on basically fentanyl and other drugs. And again, if we can get in front of the addiction problem, absolutely agree, but I've yet to see all the things that go on the providers have any difference in the number of overdoses. So I'm just, I certainly like the alternative. I certainly hear that if I prescribe past 5 days, which we don't, or you try to, those are the rules, that it can risk the addiction. I hear all of that. But again, we're putting the onus on the provider and the hospital when I've seen this every session, and yet we're seeing more overdoses. Just more of a comment.
Thank you so much, Senator Titus. Any other questions? Dr. Joseph, unfortunately, we're out of time, so I just want to make sure that we can talk offline. So any other questions? Let's move on to support testimony. If folks want to come and support the bill, you are asked to come forward at this time. We will start here in Northern Nevada and then go down to Southern Nevada. Again, the 15-minute time limit exists, so just make sure your comments are up to speed. Please begin.
Good afternoon, Chair and Committee. My name is Sabrina Schnur, SABRINA-SCHNUR. I'm here today on behalf of the Nevada Psychiatric Association. We think this bill is a great way to help folks who live with substance use disorder or who may be at risk of substance use disorder to have a plan in place before hospitalization. NPA encourages patients to have plans such as this and the Psychiatric Advance Directives in place. Thank you.
Thank you, Chair Doniate. Robert Purdy, for the record, PURDY with Silver State Government Relations on behalf of the Nevada Opioid Treatment Association. The Nevada Opioid Treatment Association is a coalition of providers of medication for opioid use disorder who treat the terrible downstream effects of not having enough non-opioid directives in place throughout Nevada's healthcare system. Our clinics do not have enough capacity to treat the Nevadans who need us, and we really need to attack the faucet on this. This is a crisis, a silent killer in our society that affects my family, and I assume it probably affects a lot of yours too, and we need to do something about it. Thank you.
Good afternoon, Chairman and fellow committee members. Douglas Geinzer for the record, G-E-I-N-Z as in zebra, E-R. I come before you today as a Nevadan for 32 years. A father, a husband, and a veteran. Sadly, we all have personal stories similar to what you've heard today. I hail from Western Pennsylvania, where the opioid epidemic has taken several family members, friends, fraternity, and military brothers from me. I suspect the same is true with every single person in this room today. I want to share with you a very powerful metaphor. There comes a point where we need to stop just pulling people out of the river. We need to go upstream and find why they're falling in. Bishop Desmond Tutu. Today, looking at the floor and people that were in the room, I estimate there were over 100 here today. What does that mean? If all of us had a surgery today, tomorrow, at least 10 of us would become addicted involuntarily to opioids. AB 337 helps correct this by giving citizens of Nevada the opportunity to opt out of opioids through the simple use of an advance directive. Just like we have an advance directive for do not resuscitate, DNR, do not intubate, this would allow us to stop opioids from being prescribed in the first place. It simply informs doctors of your desires to not be given an opioid unless absolutely necessary. And as several of the doctors before me testified today, opioids are not needed in 90% of the surgeries done today. I want to touch on an extremely vulnerable population when it comes to opioids, our U.S. veterans. Dr. Lou Tripoli, who was the Rear Admiral of the U.S. Navy, was supposed to testify today but was unable to. He has seen firsthand, as have I, how the opioid crisis has destroyed retired and inactive military personnel, as opioids were once used as the first line of defense for not only physical pain, but mental pain that was disguised as physical. The veteran addiction rate is higher than any other population out there, and today we lose 22 veterans a day. 22 veterans a day to suicide, many of which started from an opioid addiction. The indirect costs of the opioid crisis wreak havoc on Nevada's Medicaid budget, as Medicaid is the final safety net before an addict falls into the river, as quoted in the earlier metaphor. When one of our brothers, sisters,
Sir,
daughters, or
if
sons...
you can please complete your remarks.
I will give one stat that I was reading last night on just the Medicaid management of an opioid disorder. In 2013, the national Medicaid budget spent $9.4 billion on an OUD. By 2019, that rose to $23 billion. And in 2023, it's now $29 billion. That is a 300% increase managing this.
Unfortunately, your time has been run out, and if you can send your remarks to our secretary, that would be greatly appreciated.
Thank you. Appreciate it.
Let's go to Las Vegas, please, and then we'll come back up here.
Good afternoon. Chair Senator Donate, Vice Chair Taylor, entire committee. My name is Wolfgang Gilliar, Gilliar. I'm the Dean at the College of Osteopathic Medicine at Toro, Nevada. There are many lessons of bad in the story of the opioid crisis. One class of drugs from OxyContin that was actually introduced not until the 1990s to the illegal synthetic opioid fentanyl, opioids have turned the health system and our communities upside down with devastating consequences. The current opioid crisis ranks as one of the most devastating public health catastrophes of our time. One major conclusion is that the opioid crisis represents a multi-system failure of regulation. Driven by our medical students, our faculty, and many horrific patient stories, this one central question arose. What can we do at the College of Medicine to mitigate against and to prevent these horrendous detrimental effects and unacceptable adverse outcomes? Pleased to report you that we developed an innovative standalone curriculum that is actually two-pronged to lead to better and safer pain control and prevention. First is, we need to prevent this from happening again, and our medical students will be educated about the lessons we have learned and the failure of the medical system and others. And then we are teaching about specifics of alternatives to opioids, including osteopathic principles and practices, including multidisciplinary approaches, physical therapeutic ways, and state-of-the-art pain management. This curriculum is meant for all incoming medical students, and we are looking to make this a certificate course. We would be happy to share this curriculum with any other medical school or other programs simply to enhance the education and prevention. And I was thinking the role of legislator is either to prevent bad things from happening or to correct the course of things that were bad and we are trying to prevent them from recurring again. And for this, we support SB 337. And thank you for paying attention to this bill. Thank you.
Hello, Chairman and committee members. Thank you for letting me speak. My name is Mitchell Lawton, Laughton. I'm the owner and president of the Lawton Company and a second-generation Nevadan. My business has been in the employee benefits consulting business for over 50 years in the state. The reason that I'm coming here in support of this bill is I feel that this is a way that we can finally get our employer groups. They don't want to, they want to prevent addiction. They don't want to manage it. They don't need another thing as an employer of something to manage and something to do. This bill provides an easy way for employees to be able to make an election and opt out of opioids through an open enrollment process. Anyone who's intimately involved with the open enrollment process, we can easily put the election form on either the online enrollment formats, or we can also do a paper enrollment for people, and it would not take very much time or labor for them to do it. Employers spend over $2.6 billion per year treating opioid addictions, and we feel as though the best way to be able to avoid that cost is to prevent it up front. Businesses can lower their healthcare costs by over $5,300 per person addicted if they can just prevent that person from being addicted. I'm in support of Bill 337. I believe that an ounce of prevention is worth a pound of cure. Thank you.
Thank you so much. Let's come back here to Carson City. Please begin.
Thank you for your time. Alex Logan, just representing myself. But I've been a firefighter in Clark County for 17 years. 7 of those years I worked on Las Vegas Strip. And I can say that I've run on an overdose over almost every single day for the last 17 years. The problem has gotten so bad that every single fire engine and fire truck in the county has a box of Narcan where we can run an overdose call, treat the patient, and then when we're ready to leave, we hand them Narcan for when they overdose again in the future. So anything we can do to stop opioids getting into the public is something that I support, and I support this bill. Thank you.
Good afternoon. Angie Wilson, last name Wilson. I am the director for the Reno Sparks Indian Colonies Tribal Health Center, the largest tribal health center in the state of Nevada. And I would just be amiss to not say that for our American Indian Alaska Native people, the drug overdose rates in our communities is devastating. There was an OIG report that in American Indian communities, this death rate rose by 291% across Indian country. And in both 2021 and 2022, we do know that our American Indian Alaska Native folks, the rates increased another 15% from 56.6 deaths per 1,000 to 65.2, the highest death rate in any other ethnic population. And so I think that any step that Nevada can take to curb this issue in Indian country is significant. And for the fellow folks that were up here, I too have to administer Narcan, even for folks that are not eligible for our services but are passing through the Truckee River where our clinic is located. There have been multiple times that our staff have had to administer Narcan repeatedly. So I think it is a big issue. It certainly is for the tribal communities that we serve. Thank you so much for allowing me to speak.
Good afternoon, Chair Donate, members of the committee. For the record, David Cherry, Government Affairs Manager for the City of Henderson. We all recognize the opioid crisis has affected our community, and the City of Henderson has been working to raise awareness among our young people through our Don't Risk It All with Fentanyl campaign. We also look at this issue through the lens of a self-insured employer that provides health care coverage to our workforce, and we see the benefit of SB 337 when it comes to options the bill offers to patients regarding opioid alternatives. And finally, as the previous speaker mentioned, our firefighter, paramedics, and EMTs see the effects of opioid misuse on a daily basis, as does our police force. So, and if we can address the addiction issue by preventing folks from being exposed to these and becoming addicted, we see the benefit to our community and all communities in Nevada. And we thank the sponsor for bringing this bill forward.
AVH, is there anyone online in support of this bill?
To testify in support, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in support at this time.
Thank you so much. Let's move on to opposition testimony. Is there anyone opposed to this bill? Please come forward. Seeing none here or in Las Vegas, AVH, is there anyone online?
To testify in opposition, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in opposition at this time.
Thank you so much. Let's move on to neutral testimony. Is there anyone that would like to testify in neutral? Please come forward.
Good afternoon. My name is Patrick Kelly with the Nevada Hospital Association. I just want to thank the sponsor for bringing this very important legislation and for spending time with us to address the implementation issues related to it, and we look forward to continued discussions. Thank you.
Blaine Osborne, Nevada Rural Hospital Partners, for the record. Ditto. We look forward to seeing the amendments. Thanks.
Thank you, Chair, members of the committee. Adam Plain, PLAIN, Insurance Regulation Liaison with the Nevada Division of Insurance. We submitted neutral testimony on the bill as a matter of policy. It's available on Nellis, I believe, for evaluation. Unfortunately, this is the first bill we've encountered this session where we are unable to reach a conclusive evaluation as to the effects of federal defrayal resulting from the bill. I provided an explanation of how the essential health benefits framework works for pharmaceutical benefits as opposed to pure medical benefits. And unfortunately, the division just does not have staff resources available to fully evaluate how certain opioid and non-opioid medications fit into those various pharmacopoeial categories. So we do not know whether a mandate to require non-opioid medications would exceed the current essential health benefits benchmark plan. We are open to working with any interested parties and partners that want to help us through that process. But again, at this time, we cannot conclusively evaluate this bill in terms of federal defrayal.
Chair Janate and Committee, Shelley Capro representing the Nevada Association of Health Plans. We want to thank the sponsor for meeting with us earlier, and we just want to put a couple of things on the record. We, regarding the non-opioid directive form, we will be required to provide this form online and to every enrollee. It is the understanding of the association that we read these provisions, that once a form is filled out and returned to the practitioner, medical facility, or insurer, it immediately becomes a legally binding document regardless of who receives the form and whether the directive is communicated to all parties that have to be legally binding by it. We'd like to ensure that liability protections are in place for all parties involved in this process. The association also has clarifying questions on the sections of the bill that seem to allow the state to reduce reimbursement rates or prohibit medical facilities and practitioners from receiving payments if they are not in compliance. Our members have provider agreements in place that include provisions on reimbursement, so we'd like to have further understanding of how we can carry this out. And we, again, want to thank the sponsor for working with us, and we look forward to working on these issues. Thank you.
Anyone else? Seeing no one, AVH, is there anyone online in neutral?
To testify in neutral, please press star 9 on your phone to take your place in the queue. Caller with the last 3 digits, 225, please press star 6 to unmute yourself.
Hi, my name is Katrin Ivanov, KATRIN-IVANOFF. That's fine on neutral because I'm jumping between this session and the gun grabbing committee session, so I wasn't able to hear the presentation of the bill. However, in the small one sentence aiming at reducing opioid use and promoting non-opioid alternatives, I wanted to please express my appreciation for at least starting the conversation. As it comes to the view, I wasn't able to hear if there are some pros and cons, so I can really make a negative or positive determination, but I'm happy that at least you guys are talking about that, and I just wanted to express that. Thank you for good work. Have a lovely day. I'll talk to you soon. Bye.
Chair, there are no more callers in neutral at this time.
Thank you so much. Senator, do you have any closing remarks? Quickly, please.
Saju Joseph, SAJU, last name JOSEPH. Thank you, Senator Donate. Senator Titus, I wanted to give you a brief answer to the question you had posed. I cannot give you state level data because this is relatively new. I can give you data again that was what we presented in our compliance. That was with our Anheuser-Busch distributors who did note a substantial drop since they've moved their surgical volume over to our practice in their opioid addiction numbers. And then also Walmart also presented their data as well. And we were one of their larger surgical bundles providers in Las Vegas. And as I said, we've done over 400 of these cases. So we do believe that there is a reduction in opioid addiction that is translated from the directive into practice.
Thank you. Senator Titus?
Just a comment to all, I appreciate all of this, and for those, there is a real segue with injured workers and addiction, and I will tell you all to listen to a song by Jason Isbell called The King of Oklahoma. And if you haven't heard that song, you need to hear it. It's an injured worker gets addicted, ruins his life. Anyway, having said that, that's all I have.
I'll add it to my playlist.
It's not already on there, sir?
Homework to do. I'll go ahead and close the hearing at this time, and we'll move on to the next one. And so I'm going to go ahead and open the bill hearing on Senate Bill 312. This bill enacts provisions relating to the health of American Indians, Alaska Natives, and Native Hawaiians. And I'm very glad to welcome back Ms. Wilson to Senate HHS. So please begin when you're ready.
Thank you, Chair. Brett Scalari, Strategies 360. Here on behalf of the Reno Sparks Indian Colony, it is my honor to introduce Ms. Wilson to you all. I know you all worked with her many of you worked with her in the interim on this bill, and we just sincerely appreciate this hearing, and I'll turn it over to her. Thank you.
Thank you. First, I'd like to say waklisi, tusiga medikcha, ilikatigechi Angie Wilson, masasula aye, mosap ketcha. So thank you for allowing me to be here and speak to you all today. My name is Angie Wilson. I'm the Executive Director for the Reno Sparks Tribal Health Center here on behalf of the Reno Sparks Indian Colony. I would like to also mention that Chairman Gardapi really does appreciate having met with most of you. He could not be here today as they're laying to rest former chairman from Pyramid Lake and former National Indian Health Board chairperson Vinton Howley. So our condolences to the Pyramid Lake Paiute tribe and to those of you who spoke on grief and loss issues today. So thank you for that. I just wanted to talk a little bit, a recap, and just say thank you so much for allowing me to have been working with you during the Joint Interim Committee. And as a result of that presentation, which was in history here for Nevada, it was really great to be able to do that. We talked about a lot of things. We talked about how American Indians and Alaska Natives have lived under federal Indian policy and the impact of those policies as it relates to what health disparities look like in American Indian communities today, specifically here in Nevada. And as a result of that, we talked a lot about how those health disparities have been impacted because of that. We talked a lot about opportunities to improve mechanisms that we can do to work together as tribes and state to strengthen the healthcare delivery system for American Indians, Alaska Natives, and I'm excited to follow up on that here today. So I just want to talk briefly about the importance of what I feel like really came out of this proposed bill, or 312. We'll talk a little bit about tribal sovereignty and the federal trust responsibility, our government-to-government relationship, the complexities of the Indian healthcare delivery system, in addition to those federal requirements. Obviously, we'll talk a little bit about disparities, but also about the tribal expertise, our challenges and our concerns, and how SB 312 really helps to bring that all together with the Tribal Health Authority Council. So I think it's probably really important to reiterate this today. And for those of you who we've met directly, I just want to say thank you for giving us the opportunity to meet with you all. Just as a reminder, especially with some of the changes happening at the federal level, that I just want to remind everybody that the United States government and federally recognized tribes operate on a government-to-government principle, meaning that we treat each other like a separate nation in most respects. And Indian tribes exercise inherent sovereign powers over our members and our territories. And the United States Constitution contains a number of provisions that outline the federal government's relationship with tribes. The federal government has a unique relationship with our Indian tribes derived from the Constitution of the United States, treaties, Supreme Court doctrine, and federal statute. And recently, we know that there's been DEI initiatives that have taken place under the new federal administration. And so I just want to address that so we all know that there is a tribal exemption to the DEI initiatives, and that's partly because of the canon of construction, that there's a unique trust responsibility between the federal government and Indian tribes. So we're not a race-based relationship, we're a political relationship with the United States federal government. And that is how the state comes into play when Indian tribes exercise our rights to health care and things along that line, because the state does play a part in that. The state does get what we call 100% federal medical assistant percentage, meaning 100% reimbursed on behalf of American Indian and Alaska Native Medicaid beneficiaries who seek care in our Indian health, tribal health, or urban Indian programs. And we'll talk a little bit about that here recently. But I did include for you the memorandum that did come out from the Department of Health and Human Services that describes the canon of construction that reaffirms that relationship. And of course, we're meeting with Secretary Kennedy, the new incoming Secretary over the Department of Health and Human Services, in regards to ongoing issues related to the Indian Health Services and, of course, everything that's Medicare, Medicaid services as well. This was a picture of him recently meeting at the Secretary's Tribal Advisory Committee meeting. Of course, we have our government-to-government relationship here between the 28 tribes in Nevada with our state and all of you, our leadership here and also with the Nevada Indian Commission. And we value these relationships in a significant way. And we'll talk a little bit about how those relationships really fare out. I also, in my additional duties, I serve on the National Centers for Medicare and Medicaid Services Tribal Technical Advisory Group, and I represent all of the tribes in Arizona, Nevada, and Utah. And yesterday and this morning on Washington, D.C. time, we were meeting with the current administrators over CMS until Dr. Oz is confirmed, and then we'll be working directly with him. So we did meet with Steph Carlton, the acting administrator and principal deputy administrator and chief of staff for the Centers of Medicare and Medicaid Services, and Drew Snyder, the director of the Center for Medicaid and CHIP Services and the deputy administrator, on key issues that are really specific to Indian tribes and how we obtain care. We also work directly with the Consumer Information and Insurance Oversight, or what we know as the CIO, on everything related to the federal exchange and, of course, our state-based insurance exchanges. So we meet directly with them on the success of those programs. And so with this, I will say that we've always had a really good working relationship here with the state of Nevada, and we're very vocal about that when it comes to working on the national level. We oftentimes refer to the great tribal consultation practices that are exercised in this state. I'm a California tribal member, and I can tell you, I use that example every single time I meet with the state of California on how well Nevada has this under control and that they should attain to that. But we also work on things such as when Nevada had the whole body, whole mouth dental 1115 waiver, it was held up with CMS for quite some time. And we're able to champion that along at the national level of what's going on with that waiver. And so we can use our voice as tribes to push issues along for Nevada that impact our tribes, but also impact Nevada overall. I serve as the chairperson, the tribal chairperson for CMS's Medicare and Medicaid Innovation Center, and where we talk a lot about things like payment methodologies for states, things along the line of improvement models and things along that line. So we're excited to be your partner as we go through the process. Obviously, we can talk a little bit about the complexities to the Indian healthcare delivery system. And of course, you know, our tribes have the ability to operate our tribal healthcare directly. We also have the right to retain any of those services with the Indian Health Services. And there's some complexities on who's eligible for what service, and that's all depends on a multitude of factors. So that could be complex in itself. For Medicaid-covered services provided by our direct healthcare facilities, our Tribal 638, like I mentioned, American Indians and Alaska Native Medicaid beneficiaries do not cost the state a dime. The state does get 100% reimbursement as long as those folks are getting care through our facilities. And I also just want to mention that the Reno Sparks Indian Colony, we championed the state plan amendment several years ago for a new tribal Medicaid federally qualified health center designation that now allows the state 100% reimbursement for services that are also procured through our clinics. So if we're referring to Medicaid specialty providers, those instances will now be extended to the state at 100% reimbursement. So that's part of the reasons why collaboration between the tribes and the state is really important, because there could be additional methodologies that not only support tribal health care in our communities, but also do the same to support reimbursement to the state, because we do believe that there's a federal trust responsibility that the state should not have to be paying for that, so we can continue to work on that. For the provider enrollment and licensing exemptions, we have exemptions where healthcare professionals that are employed by tribal healthcare are exempt from licensing requirements of the state in which the services are performed, as long as they are licensed in any state. That's similar to what the VA does in its licensing requirements. Also, in regards to enrollment of insurance in Federal Tort Claims Act, our tribal health providers are covered by federal tort. So the federal government does become responsible for negligence or wrong acts of tribal health providers unless it's an on-the-job injury, which is covered by workers' comp, a breach of contract rather than a tort claim, or acts performed by employees outside of the scope of employment. Now we kind of get into a little bit more difficulty when it comes to state-based Medicaid programs. And so when we look at Medicaid managed care organizations, and I know that Nevada is planning to expand rather than just having it Washoe and Clark County, to look at the entire state. There are some very specific provisions in the law that managed care organizations must contract with the state, must also require the managed care organization to demonstrate sufficient Indian health, tribal health, and urban Indian programs in networks for MCO-enrolled American Indians and Alaska Natives to have timely access to Medicaid-covered managed care services. Also, to pay our Indian health, tribal health, and urban Indian programs, whether we're contracted or not. And that Medicaid-covered managed care services provided to MC-enrolled American Indians is at a rate that's not less than the amount that would be payable to a contracted ITU provider. To make prompt payments to the Indian health, tribal health, and urban Indian programs, whether contracted with the MCO or not. And of course, to pay our clinics that are FQHCs, whether we're contracted or not, for these services. If the amount paid by the MCOs to a non-federally qualified Indian health or tribal health or urban Indian program is less than the IHS and county rate, then the state Medicaid plan must provide payment for the difference between the MCO. I can tell you that not only in our state, but, you know, of course, because the Reno Sparks Tribal Health Center is located in a managed care required state, which county, which is Washoe. This is not a lone issue here for Nevada. It's across Indian country. In every single state, we run into the similar issues. So much so that we did champion this right here, which is the Tribal Protections Toolkit that actually went out to all states that operate Medicaid programs to really go into the laws on what they say, because there's so many issues when it comes to accessing care. And so this is how these partnerships or collaborations between the tribes and the state can really benefit each other to deter those. Of course, there's exemptions for American Indians and Alaska Natives from cost sharing. Those cost sharings extend to Medicaid premiums and cost sharing, and I noted the CFR there. Also, for the children's health insurance premiums and cost sharing, there's exemptions for American Indians. And of course, for qualified health plan premiums and cost sharing under 45 CFR, if household income is equal or less than 300% of the federal poverty level, and there is verified membership in a tribe, or under Section 1402. D2 of the Affordable Care Act, if they receive care through the Indian Health, Tribal Health, or Urban Indian Program, or purchased and referred care. Of course, there's American Indian, Alaska Native federal rights under Medicaid managed care. So we have the right to exempt ourselves from an MCO or a PCCM program, unless that program belongs to an ITU or Indian Health, Tribal Health, or Urban Health Program. And that American Indians enrolled in managed care have the right to select an in-network, which includes our tribal clinics. So I want to talk a little bit real quickly about tribal expertise in healthcare, and this is really where SB 312 comes into play. So providing care, we provide care within a maze. It's, I'm sure, confusing to you. Is confusing to Indian people too. So believe me on that. So Indian Health Services funding is subject to many different federal regulations, which differ between programs and between tribes. It can differ between me as an enrolled member of California and a Nevada tribal member on what we're eligible for. That could change if I start working for the tribe. So there's so many caveats to that. Also, creating and administering programs with limited funding. One of the biggest payers of third-party revenue across Indian country, across the entire United States, is Medicaid. That's a significant issue for us, and one that we're addressing with the new Secretary of DHHS and with CMS. And of course, we appreciate Governor Lombardo's letter he penned in regards to the importance of Medicaid here in the state of Nevada. But also things like community health programs. When the community health worker program rolled out, this is already one of the longest standing programs in Indian country since 1969. But unfortunately, when the state rolled out the community health worker program, there was not a consideration that there's been a long-standing, almost similar community health representative program, so that created additional barriers. But had we had better collaboration, we could have addressed those ahead of time. Of course, there's social determinants of health, which all of the 28 tribes here deal with their tribal members, and how to address things like limited housing, food banks, food vouchers, energy cost, employment, education, case management, those types of things. And then, of course, culturally appropriate services that we really strive to provide in our tribal communities. We have various best practices like creative solutions with limited funding. You've heard about some of that with the state plan amendments, and I will just say this. One of the things that I discussed with you all during our interim time was the idea of our pharmacies being reimbursed at a higher rate or more open rate. And I'm really happy to announce that we've worked really closely with the Department of Healthcare Financing and Policy, or Nevada Medicaid, with the Department of Welfare and Supportive Services, and we pushed for a state plan amendment. That was accepted by CMS Region 9, and we just got word just a couple weeks ago that state plan amendment has now been approved by CMS, which changes the relationship with the state and CMS and completely opens the door for the tribes to be able to bill for any type of medication for Medicaid beneficiaries, and extending not only that allowed and improved payment methodology to the tribes, but now extends 100% FMAP to the state for millions of dollars in additional savings. So we're excited about that. Of course, there's challenges in Indian healthcare. We deal with a lot of the same things: provider recruitment and retention, common vacancies. I'm concerned about things like maternal infant health. That's a big one for us. Long-term care, remote areas with few healthcare options. And I think I've stated before that in Nevada, it's not just about the Reno Sparks Indian Colony. We look at this of all Nevada, which most of our counties are frontier. And so that's a huge issue when it comes to our tribes as well as other Nevadans. But we also deal with things like cultural barriers, discrimination and mistrust. Those are long-standing issues. Communication challenges, a lack of understanding of the Indian healthcare delivery system outside of Indian country. And of course, American Indian, Alaska Native health literacy. How can we help our patients better understand these processes? So we held the meeting with the Joint Interim Committee where we presented on this, I believe, back in February. We had a follow-up presentation, and we appreciated your invite to come back and talk about access to behavioral health for tribal youth. That was really pivotal. And of course, we worked with you all on the collaboration of a draft BDR language to form a Tribal Health Authority Council that was mirrored from the successful Washington State and Washington Tribal Health Advisory Council initiative that's been initiated in the state of Washington. That's very successful today. We held work sessions attended the work session with the BDR, where the Tribal Health Authority Council BDR was unanimously passed by the Joint Interim, and we appreciated that. And just a quick summary, these are the items. Section 1 just asks the DHHS to apply for federal authorization allowing tribal benefit coordinators to determine Medicaid on site. Section 2, to amend Nevada law to include new provisions regarding Medicaid eligibility determinations made by Indian Health, Tribal Health, and Urban Indian programs. Of course, that's a benefit to the state because as long as we can keep people on, it passes the savings on to the state. Sections 3 and 4 define Tribal Health Authority Council as the official advisory body for Nevada American healthcare matters. And Section 5 creates and defines the Tribal Health Authority Council, specifying its structure, like voting members from Indian Health, Tribal Health, and Urban programs, the legislative representatives, and also includes non-voting members, such as all of the tribal liaisons with our state agencies. Section 6 outlines the council operations, meaning quarterly meetings, the election of the chair and vice chair, and rules for quorum and voting. Section 7 establishes a coordinator of the council appointed by the executive director of the Department of Native American Affairs, and that the department staff must provide staff, facilities, and resources to support the council. Section 8 assigns responsibility to the council, including assessing Native American healthcare needs, developing plans to improve healthcare access, and identifying barriers and proposing solutions. Section 9 creates the Account for Tribal Health, a dedicated state fund to support the council's activities, which would allow the department to receive federal and private funding. Section 10 allocates $224,000 to the Department of Native American Affairs for the council's operations. I believe that's for a staffer. And any unused funds would be returned to the state by September of 2027. Section 11 requires the Department of Health and Human Services to work with the council to develop a Medicaid reinvestment proposal. Again, that's from the new state plan amendment where we extend additional savings for services that are provided through our clinics, and to submit recommendations to the legislature by June 30th of 2026. And then lastly, Section 12 establishes timelines for appointing council members and enacting the bill's provisions. So that's just general overview. I want to just say quickly how much I appreciate the opportunity. I will say this has been big news in tribal healthcare world. The discussion of being invited to the Joint Interim Committee, this discussion of the BDR, the work session, and of course meeting with all of you, some of the new faces here on this initiative. And I think genuinely it gives us the opportunity between the 28 tribal nations and our state to have better collaboration a longer term on things that we can do here in our state. So any questions or anything?
Thank you so much, Ms. Wilson. It's always a pleasure to have you here. I know we've worked extensively behind the scenes, and if there's things to change in the bill, we'll work in terms of the technicalities and the semantics, but obviously it's about building the infrastructure so that we can address the longstanding barriers, and I just want to thank you for that. So any questions? Senator Titus.
Thank you, Mr. Chair. Great to see you again. Great discussions about the need, and hopefully this will help. I do have some questions the way the bill's written, however, Chair. So tribal members, if they're Nevada residents, can already apply for Medicaid based on the same criteria that every other Nevadan has to apply for Medicaid. What this bill, if I'm understanding, it doesn't create that they suddenly can apply. What it's helping them have a tribal coordinator to look at who can apply and encouraging them to apply. So that's, I just wanted to get that on record. My question is actually on specifically to Section 5 and the council. I've sat on a lot of interim committees, different committees, and worry. I know they're supposed to serve without any reimbursement, but one of the issues, especially when we had, when you say one person appointed by each Indian tribe in the state, and there's potential 21 nations, correct?
Yeah, 28.
28, sorry. So one of the issues, many times, we couldn't get a member to serve because they couldn't get to these meetings. They didn't have access. They didn't have travel. They wanted to help, but they couldn't get there. And so I worry about with not having any source of helping them. I know that the director will appoint the coordinator. The coordinator will get paid, and there's not clear on how that works. But so you have somebody coordinating this group. I just worry about this volunteer group and the actual participation. If they're able to participate, I just worry that, again, some of these tribes that need it so badly to be a participant won't be able to participate.
Yeah, I think it's a good comment. And one thing I would just say to that is currently we hold quarterly consultation meetings with the divisions of Health and Human Services here, from the Office of the DHHS Director to Nevada Medicaid to the Department of Welfare and Supportive Services, Aging and Disability, Child and Protective Services, a number of different folks. We meet once a quarter. I think what happens, though, is it is something that we do look at in regards to participation, and we have tried to actually host them in Indian country. So sometimes we'll host them from my clinic at Reno Sparks. We'll also allow for participation on via Zoom or Teams for better participation.
Right. That's where I was going with it. Is I don't really see it mentioned that it has to be in person, the meetings, and if you had, perhaps I know we're working hard to get communications, satellite, and internet availability, but I think it's really important that they're allowed like a Zoom component to it.
Yeah, thank you. Senator Tice, to answer that question, I think that's the meeting that we have tomorrow scheduled, post hearing. It's more to tighten up whether or not it's feasible for all these members to be represented, and I think we're gonna look at what the rotations would look like, or maybe it's their preference if they have a tribal health, like an FQHC already established and so forth. And so we're going to talk more of the semantics of lowering it, but if there's a recommendation to make sure that they're paid and so forth, so it's more of a commission or how we have other
For me,
parts of government.
it's access and participation.
Ms. Wilson, and the name for the record, please.
Oh, yeah, Angie Wilson, for the record. One thing I would just also say is that the 28 tribes are represented by the 12 ITUs. So even though it wouldn't be all 28, it would be the 12, the Indian Health, Tribal Health, and Urban Indian programs, because we represent all of the tribal health care for all of the tribes. So it's not as many as 28 people, but it's the ITUs that represent those tribes that we serve and service delivery area. Yeah.
Any other questions or comments? Seeing none, let's go ahead and open it up for support testimony. Again, the 15-minute time frame is still the same. So if you would like to support this bill, please come forward. I think we have a few folks both here and in Southern Nevada. Let's start in Southern Nevada because we have one folks there, and then you guys can come forward. Please begin.
Aloha, Chair Doniate and members of the committee. My name is Christian Solomon, CHRISTIAN, SOLOMON, and I'm the West Regional Director of RISE, speaking in favor of SB 312. I'm a proud Native Hawaiian and in full support of expanding and streamlining access to healthcare resources for our Indigenous and Native Hawaiian community, and placing the power to do so directly in the hands of community. I am looking forward to seeing this bill establish the Tribal Health Authority Council, taking on the responsibility of improving the health of our Indigenous brothers and sisters in our state, Thank you so much for your consideration, and please support SB 312.
Thank you so much. Let's start here in Carson City.
Good afternoon. Yvonne Powers, YVONNE-POWERS. I'm a council member with the Shoshone-Paiute Tribes of the Duck Valley Indian Reservation, and I just want to say that we are in support of this bill.
Hello, Will Adler with Silver State Government Relations for the record, usually with Duck Valley and Pyramid Lake Paiute Tribe, but I would love them to speak for themselves. So for Pyramid Lake Paiute Tribe, we wanted to say that this bill brings forth a lot of focus where there is not focus today on tribal health issues by bringing forth the Tribal Health Council that could actually help facilitate additional benefits or just knowledge around benefits that are available for tribal members through the Medicaid programs and other programs out there. Really, it's a lack of knowledge and facilitation that this bill could actually fill that gap of. So thank you for bringing this forward, and any funding that is required is in the best place. So thank you so much.
Good evening. My name's John Pishon, Jon-Pishion. Oh. Okay, sorry about that. John Pishon, Jon-Pishion. I'm the health director for the Fallon Paiute Shoshone Tribes Health Center. My health center serves pretty much all of central Nevada, including for the tribes of Lovelock, Yumba, as well as for Pershing County, Humboldt County, and a few other counties that we serve. So I have been working with Ms. Wilson on this, trying to create some type of advisory board to help work with tribes. One of the biggest issues that we have faced is coordinating with all the tribes on health issues. And I believe this bill that you guys are working on, SB 312, would be a great benefit to tribes all here in Nevada and help us better coordinate healthcare services for our members. Thank you.
Thank you so much. Anyone else here in Carson City? AVH, is there anyone online?
To testify in support on SB 312, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in support at this time.
Thank you so much. Let's move to opposition testimony. Is there anyone in opposition? Seeing none here or in Las Vegas, AVH, is there anyone online?
To testify in opposition, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in opposition.
Thank you so much. Let's move on to neutral testimony. Is there anyone in neutral? Seeing none here in Las Vegas, AVH, is there anyone online?
And to testify in neutral, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in neutral at this time.
Thank you so much. Ms. Wilson, do you have any closing remarks?
I'd just like to say, Subketcha, thank you all for allowing us to speak, and we look forward to the meeting tomorrow. Thank you.
Thank you so much. I'm going to go ahead and close this hearing and move on to our final one, which is for Senate Bill 192. This bill revises provisions relating to public health, and I will go ahead and pass the gavel to our Vice Chair.
Thank you, Chair. And as you said, we're now going to open the hearing for Senate Bill 192. This bill revises provisions relating to public health. And our chair is coming forward and will present this bill. So, of course, Chair, begin when you're ready.
Thank you so much, Vice Chair Taylor and committee members. For the record, I am Fabian Doñate, representing Senate District 10 in Las Vegas. Thank you for the opportunity to present Senate Bill 192 today on behalf of Senator Neal. It's an honor to get the chance to present it on her behalf. I want to go over just quickly of the provisions of the bill. I do have co-presenters in Las Vegas and on Zoom who will provide just brief remarks in terms of what the rationale of is or what they were working with Senator Neal on the bill. We will try our best to answer the questions that we can, just understanding that we may have to follow up offline. Quickly on sections of the bill, Section 1 requires a hospital or a freestanding birthing center to provide a qualified sign language interpreter to a patient who is at the hospital or freestanding birthing center for the purpose of giving birth. Section 1 also requires a hospital or freestanding birthing center to allow a family member of the patient or a doula to be present in the room when the patient during the birthing process. Sections 2 to 6 of this bill make conforming changes relating to the applicability and enforcement of Section 1. Section 17, 18, 43, 46, 48, 50, 51, 53, 55, 56, and 61 requires various other public and private insurers to cover maternity care to cover doula services and include doulas in their networks of providers. Section 45 authorizes the Commissioner of Insurance to require certain policies of health insurance issued by a domestic insurer to a person who resides in another state to include the coverage required by Section 43. Section 60 authorizes the Commissioner to suspend or revoke the certificate of a health maintenance organization that fails to provide that coverage required by Section 55. The Commissioner is also authorized to take the same action against other health insurers who fail to provide the coverage required by Sections 43, 46, 48, 50, 51, 53, and 61. Sections 44, 47, 49, 52, 54, 58, and 64 recovers the coverage of testosterone replacement therapy for menopausal women and any other type of hormone replacement therapy lawfully prescribed or ordered that has been approved by the FDA. Sections 20 requires Medicaid, including where benefits are not provided through managed care, to cover hormone therapy, including testosterone replacement therapy for menopausal women, and it also requires the director of DHHS to apply for any waiver of federal law and amendment to implement the provisions of this section. Section 16 makes conforming changes to require DHHS to administer the provisions of Section 20. Section 21 expands existing coverage of dental services under Medicaid and provides that to the extent federal financial funds are available, the director shall include coverage for preventive, diagnostic, periodontal, and restorative services. Section 42 prohibits certain health insurers from denying a request to include a provider of healthcare in a provider network because the provider of healthcare is a solo practitioner. Sections 19 of the bill additionally requires the Board of Trustees of each school district and the governing body of each charter school or university school for profoundly gifted pupils to adopt a policy concerning the prevention of sudden cardiac arrest during the participation of pupils in combative sports sponsored by a school, and each policy must include the pupils obtain an ECG screening conducted by a healthcare provider before participating in competitive sports. Section 22 requires DCFS of DHHS to provide an independent psychiatric evaluation of the child not more than 6 months before the child achieves a permanent placement or transitions to independent living. This section provides that this requirement does not apply if a psychiatric evaluation conducted after the initial diagnosis excuse me, has determined the child to no longer has a mental or behavioral health care condition. Additionally, if the psychiatrist who conducts a psychiatric evaluation of a child determines the child still suffers from the mental or behavioral health condition which the child was previously diagnosed, and the condition has not improved, it shall be recorded in the child's medical record. Section 7 and 23 to 25 make conforming changes. Section 26 prohibits a health carrier or health insurance administrator from providing healthcare services directly to patients or operating or administering any entity that provides healthcare services directly to patients. Further, the Attorney General or any person injured by the violation of Section 26 would be authorized to bring a civil action. Sections 8 to 15 authorize the AG to use money from certain fees which are currently used to support investigations of unfair trade practices for the purpose of investigating violations of Section 26. Sections 38, 41, 57, 59, 62, 63 make conforming changes regarding to the direct provision of healthcare providers by insurers. Sections 27 provides that a non-competition covenant may not restrict the provider of healthcare employed by or contracted with the hospital from providing medical services to another medical facility or office during or after the term of employment or contract as applicable. Section 27 also provides any provision of a non-competition covenant that violates this prohibition is void. Sections 29, 32, and 35 require the Board of Medical Examiners to adopt regulations concerning the use of race-based formulas and standards used by physicians and physician assistants. Section 65 requires the Board of Medical Examiners, the State Board of Osteopathic Medicine, UNR, and UNLV to study disparities in healthcare access, the provision of healthcare and healthcare outcomes. Sections 30, 36, and 36 require a physician or provider to discuss with a patient upon diagnosing the patient with arthritis, osteoarthritis, or any other condition commonly treated using stem cell therapy and potential use of stem cell therapy to treat the condition. And then Section 37 clarifies the requirements of NRS that do not apply to prescribing or dispensing of a controlled substance in other circumstances and establishes a standard of care or grounds for disciplinary action against a practitioner when a controlled substance is prescribed or dispensed in other circumstances. And next, I would like to go ahead and introduce the folks who will co-present with me, just giving a quick background of the work that they were working with with Senator Neal. And so I would like to allow the folks, I believe we have Troy in Las Vegas and Jashante in Las Vegas, so please begin.
Good evening, Honorable Chairperson and committee members. Thank you for the opportunity to testify today in support of Senate Bill 192, which seeks to expand access to doula care and address Nevada maternal health crisis. The United States continues to face a significant maternal health crisis. The U.S. maternal mortality rate is 23.8 deaths per 100,000 live births, according to the CDC in 2023. It is the highest among developed nations. In Nevada specifically, the maternal mortality rate is approximately 16.7 deaths per 100,000 live births. Rural counties face up to 40% higher rates of maternal complications due to limited access to care, and 100% of Nevada counties are classified as maternity care deserts with limited and no access to maternity care providers. Doulas help to address and meet the educational and emotional needs of pregnant and birthing people who have limited access to perinatal providers. A 2023 study in the American Journal of Public Health found that states with Medicaid coverage for doula services saw a 15% reduction in maternal mortality rates among Medicaid recipients. The current landscape of doula care in Nevada consists of 83% of doula-supported births are to women with private health insurance. Less than 5% of Medicaid recipients utilize doula services. Rural communities have extremely limited or no access to doula care. What Senate Bill 192 will accomplish for doulas and their birthing families will ensure that doulas are no longer considered a part of the family or the plus one, rather the extension of the care team. It will also ensure that private health insurance coverage for doula services and care is available to the families. Why does this matter? It matters because it will create approximately 100 new jobs per annum for doulas who have been trained. It will potentially save an estimated 120 to 150 severe maternal morbidity cases per year. And in conclusion, every birthing family in Nevada deserves access to quality maternal support, regardless of income, location, or insurance status. Senate Bill 192 represents a critical step forward in making that vision a reality. I respectfully ask the committee to support Senate Bill 192, and I thank you for your consideration and commitment to improving maternal health outcomes in Nevada.
Thank you so much, Fabian Durñata, for the record. And next we'll have Troy. Please begin.
Hello, committee. Thank you for having me. My name is Troy Rock. I'm the executive director for Vegas for Athletes. I support Bill 192 because sudden cardiac arrest remains the leading medical cause of death in young athletes today, with a survival rate of approximately 10% when it occurs outside of a hospital environment. The standard sports physical either misses or does not check the heart beyond the stethoscope or electrical or structural heart conditions that can be identified from a 16-second ECG test. Because of celebrity athletes such as Damar Hamlin and Bronny James, sudden cardiac arrest has become more prominent conversation. But here in Las Vegas, we've had our fair share of deaths and close calls. In 2023, Las Vegas lost 3 student athletes to sudden cardiac arrest. Ashari Hughes, a 16-year-old, was playing flag football for Desert Oasis High School when she suddenly collapsed and died later at the hospital. Jordan Brister, an 18-year-old athlete from Amplis Academy, was found dead in his high school bathroom after gym class. Ryan Keeler, a 20-year-old UNLV football player, was found in his apartment due to hypertrophic cardiomyopathy. Since 2024, Vegas for Athletes has screened 632 athletes, finding 23 with heart abnormalities and 7 with life-threatening conditions. In August of 2024, I met a 16-year-old from Foothill High School who suffered a cardiac arrest at the Jerry Tarkanian gym. He was saved by a quick response with the AED, but now lives with the pacemaker and can no longer play sports. 4 months later, in December of 2024, I met the family of CJ Henley, a Coronado High School player who suffered cardiac arrest in his English class and now lives with a pacemaker and can no longer play sports. And just 2 months later, in February of 2025, we've already experienced the death of another UNLV football player, Ben Chrisman, found in his apartment. The official cause of death was natural causes, but it's reported that Ben was having chest pains during practice that day. An ECG does not directly prevent sudden cardiac arrest, but it's a crucial tool for diagnosis, risk stratification, and guiding treatment to prevent and manage future episodes, especially in athletes. Under Section 19, according to our firsthand testing results, we would find approximately 3,639 athletes currently playing sports with a heart abnormality and 11,008 athletes playing with a life-threatening condition. In a short time, Vegas for Athletes has gained the support of Clark County School District, as well as our professional sports organizations and UNLV. We are currently collaborating with the Las Vegas Aviators, the AAA team for the new Major League Baseball team, the Las Vegas A's, for a pilot program to help protect the health of our future young champions. Thank you.
Thank you so much. And Vice Chair, next I would like to go to Dr. Bayo, who's joining us via Zoom.
Thank you, Chair. My name is Dr. Bayo Curry-Winchell. It's B-A-Y-O, and it's spelled C-U-R-R-Y-W-I-N-C-H-E-L-L. I'm a family medicine physician who's representing myself and as well as a health advocate. I am speaking today regarding the section about removing race-based protocols from healthcare. So I like to kind of paint a picture because that can be really difficult to really take in what does that mean. Well, there's a current practice that if a Black individual has high blood pressure, there is a recommendation of 2 specific types of medications, that being a calcium channel blocker and a thiazide medication, solely based on the fact that that individual in front of that clinician is Black. So I am here to highlight that form of thought process as far as treating an individual based on the color of their skin is harmful. And I'd like to go a little bit deeper why that is impactful. Often, many of us here who are listening have heard that Black individuals are at a disproportionate rate of kidney disease. Well, you can imagine if you have a Black individual who is offered 2 specific types of blood pressure medications versus all of the other medications that are available to treat high blood pressure, you are going to be from the start at a disadvantage. So this practice is in play across the country and it's harmful. We should not be practicing medicine based on the color of someone's skin. And last little point, just to kind of drive this home, race is not the same as genetics. So treating an individual based on the color of their skin should not be happening in healthcare. It's harmful and it prevents an individual from getting the best care possible. Thank you.
Thank you so much. Vice Chair, I believe we have 2 more folks to talk about the other provisions of the bill. We have Dr. Hardman and Dr. Isom. I'm not sure if they're still online, but if they are, now would be the time.
This is Dr. Isom. I am here. So good evening, Chair and members of the committee. My name is Dr. Nisha Isom. It's first name N-A-Y-S-H-A, last name is Isom, I-S-O-M. And I am a board certified family medicine physician as well. I own a direct primary care and wellness practice right here in Las Vegas. And I am here to strongly urge you to support the Section 27 of the SB 192 bill. Non-competes are not just a business issue, they are a public health issue. These clauses restrict doctors from practicing within miles of their previous jobs for years at a time. In a state like Nevada, where we already face provider shortages, this leads to fewer doctors, longer wait times, and disrupted care, especially in underserved and rural communities. Let me be really clear, non-competes don't just protect patients, they protect They protect corporations. They actually keep doctors locked in toxic jobs, afraid to leave, even when the systems aren't serving them or their patients. And when we do leave, we're forced to uproot our families or stop practicing altogether just to avoid being sued. That's not how we solve a healthcare crisis at all. As someone who has worked across the country, I've seen that when physicians are free to actually leave, we innovate, we stay in our communities, and we build better models of care, and everyone wins. Removing non-competes would allow more physicians to stay in Nevada, open practices, and provide the kind of care we all deserve. This is about access, it's about community, and it's about keeping good doctors in the communities that they love. Thank you.
Thank you, Vice Chair. Fabian Nuneta, for the record, I believe we have Dr. Hardman online, so I just wanted to see, check if she's still. For the Fabian Nuneta, for the record, for the sake of time, I think we'll just go to questions if that's helpful. Yeah.
All right, thank you, Chair, and I don't think the doctor's there, so we'll go ahead and bring it here to the committee. Any questions for Chair Giannianti? Go ahead. Go ahead. I almost said Dr. Titus. Dr. Senator Titus, how about that?
Thank you, Chair. I appreciate the opportunity. And I have so many questions, I'm not even going to ask them because I promised you I'd be nice. I think the one thing I do want to clarify and get on the record, though, again, this is a huge bill. I think it could probably be broken down into 6 separate bills because there's so many different subjects in here, some good, some need work on, that it's just kind of overwhelming for this type of a bill, I believe. But I really want to clarify. There's your in your definition, and this is specific to, I don't know, it starts out, section 36, section 35. It talks about the definition of a provider of health care. And it says, as used in this section, a provider of health care means an osteopathic physician, physician assistant, or group of providers of health care that includes an osteopathic physician or physician assistant. Now, we have worked hard in this building to look at those definitions, and many bills, one we heard today, that actually adds a genetic counselor as a provider of health care. And we have social workers as a provider, we have counselors as providers, athletic directors, it depends. And I'm just wondering, I think this is probably more for our legal counsel on, would it just, for this provision, and so it excludes nurse practitioners or other providers that I see of healthcare. So I'm wondering how that plays out. Let's say this bill passes, and does that change in that NRS, then change the definition of provider of healthcare over all the things that we've worked hard to have as a provider of healthcare?
Mr. Robbins, please.
Eric Robbins, LCB Legal, for the record. No, this, the definition, well, first of all, the definition is for provider of primary care, not for provider of health care here that you're referencing. But yeah, it just, these definitions just apply in this section, in the particular sections of the bill, and so they wouldn't affect anything else in NRS.
Well, then, if I might follow up on that. So it says, number 3, as used in this section, provider of healthcare has a meaning. But I would say a provider of primary care, it doesn't include nurse practitioners?
Eric Robbins, LCB Legal, for the record. In this case,
so they would not be held to the provisions of this bill then?
Yeah, well, not, I wouldn't say this bill, but like these particular provisions that are going in 630 and.
And I guess it was an oversight of the drafters or a deliberate elimination?
Actually, no. It would include them because, so basically the way these provisions are laid out, they go in the specific chapters governing different types of providers. So they're in chapter, like in section 30, that one deals with allopathic physicians, and provider of primary care is just defined to mean a physician or physician assistant in that provision, because that's that particular chapter, and that's where that's what's regulated under that chapter.
Okay.
But if you go to section 33, there's an identical section in the nurse chapter, and for that the provider of primary care means an advanced practice registered nurse or group of providers of healthcare that includes an advanced practice registered nurse. So that's where they would be covered.
So they're spelled out in every different section. Okay, it just seemed like to me that we were changing the definition after we talked about genetic counselors today being a provider of healthcare too.
Yeah, no, as I said, this is just a definition of provider of primary care, and it's just for the particular sections where it's laid out.
Thank you, and I think we'll have a long chat on this after, but not tonight.
Thank you so much. Fabian Donato for the record. Just want to quickly answer. If the committee members have any questions specifically on the presenters that are here, now would be the time in terms of more of the intent. And we could obviously talk offline. I did forget to mention that we have not accepted any amendments on the bill, but you may see a few of them online on Nellis. That is to help us track the amendments, and so I just wanted to make that disclosure for folks.
Thank you, Chair. Yes, you want to go ahead, chime in.
Destiny Cooper, LCB for the record. I was just going to say that there are more presenters on Zoom that can answer questions. There was a doctor that just joined as well.
Okay, that's probably the doctor you alluded to earlier.
And that Ms. Cooper is Fabian Donato for the record. Ms. Cooper is referring to they can answer questions specifically on group practice and menopause. So in case if there was any provisions of the bill that we wanted to add more clarification.
Okay. Other questions from the members? Yes?
Thank you, ma'am.
Okay, please go ahead. I'm sorry,
Thank you.
Senator Stone. Go ahead,
I
Senator
noticed
Stone.
that there was a provision in there that hormones, progesterone, testosterone can be prescribed. Is that prevented today? Does it need legislation to allow physicians and nurse practitioners to be able to prescribe those medicines?
Thank you so much, Fabian Donato for the record. I'm going to allow my co-presenters to answer the second portion of it, but my understanding of the bill provisions, it's more on the payment and reimbursement of the therapy. So,
thank you, Chair. Anyone in Vegas or on Zoom, please go ahead.
This is Senator Neal. Dr. Braithwaite can't answer because she had to go deliver a baby.
That's a poor excuse, Senator.
We'll take a deferral.
I'm just saying, but I'll answer the question. So basically, currently, testosterone is not covered for women. So if they're going into premenopause or if they're starting their menopausal therapy, their average cost is about $400 a month out of pocket. And they have to pay, and where for a man, it's covered. And so the goal was to allow for the small dosage that women may need to be covered under the insurance.
Thank you, Senator. I think Senator Stone, you want to continue? Then no, Senator Titus has a question. Please go ahead.
Yeah, no, thank you. I appreciate that explanation. Can you just elaborate a little bit more on the non-competition clauses, how that might affect some of our hospitals that have exclusive providerships?
Senator Neal?
So I had Dr. Isom on for that, but I can explain why I put that in there. So when I was
I'm still on, if you want me to answer.
Dr. Isom, go ahead.
Sure, I'd love to answer that. So as I stated in my statement,
let's get your name for the record, Doctor. Doctor, let me just stop you real quick. Let's get your name for the record.
Dr. Naisha Isom, Ison.
Thank you. Go ahead.
As it pertains to the hospital systems here, we have basically two large ones that cover the entire valley. And so when you take and put physicians under non-compete, then you're actually taking physicians out of the community, and we're already at a deficit. So it's really not about protecting the hospitals, it's about protecting the communities and our patients.
And
Senator Stone, follow up, or you okay? Go ahead, Chair.
Fabian Donato for the record. Obviously, this part, I actually do know a lot about. The provisions regarding non-competitions I think what we've seen in the market, specifically in Las Vegas, is there's been a growing influence, of course, of practices that have been administered in terms of recruitment of physicians. And no, it's gone to an extent where, honestly, it's been very egregious. We have seen in the market where, for example, when we were recruiting physicians, that they would have non-competition agreements that would say you can't practice anywhere within the same specialty or same type of provider group within the 15-mile radius. Well, that's essentially the entire Las Vegas Valley. And so I think there's a question as to if we are facing such a shortage for certain provider groups or certain types of providers, why are we allowing corporations to hang over their heads this level of enforcement to restrict them from being able to access care, right? There's a question, of course, of retention and whether or not they want to stay with their employer, but we should never be placing physicians in a position where they have to feel obligated to leave the state when we work so hard just to even recruit them. And so that's more of the why non-competition agreements are starting to become problematic in the provisions of this bill. I believe that's what Senator Neal's intention was.
Thank you, Senator Stone. Senator Neal, we're going to go to Senator Titus, but it's just good to hear your voice.
Well, thank you, Vice Chair. That's exactly what I was going to say. Senator Neal, I'm so happy that you are participating, and thank you for continuing to look out for Nevadans and represent your community and all Nevadans. And thank you for just being here today, at least in over the phone, and certainly in spirit too. But more than that, thank you.
Ditto.
Thank you so much, Senators. And now we'll go to Senator Lang.
So, what Senator Stone brought up, I believe I did a bill on this for culinary 2 sessions ago that took care of this problem.
Fabian Indractor, for the record, that was more of the, my understanding of the bill that you're referencing is more of the acquisitions of physician groups, and it's more in terms of the integrations, unless Mr. Robbins wants to correct me.
Yeah, Eric Robbins, LCB Legal, for the record. Yeah, I apologize. Senator Doñate is exactly right. That there was a bill a couple of sessions ago, and I didn't recognize it when Senator Lang brought it up, just because it didn't deal with this issue exactly. But that was more about consolidation of physician groups, and it didn't deal with non-competes in this the way this bill does.
Thank you, Mr. Robbins. Any other questions from the members? We have experts online, and we have our own Senator Neal online too at this time. Okay, looks like that's good for questions. Thank you, Chair. We'll ask you, of course, to sit back, and we will open it up now for anyone who'd like to testify in support of Senate Bill 192. Please come forward here, or if there's anyone in Las Vegas, please do so at this time as well. We have 15 minutes for support, 15 for opposition, and 15 for neutral. Please go right ahead. 2 minutes. Don't mean you take 15 because you're there by yourself.
I'll be way fast.
Okay, good. Thank you. All right. Just wanted to clarify.
Thank you. Good afternoon, Vice Chair Taylor and members of the committee. My name is Catherine Nielsen, Executive Director of the Nevada Governor's Council on Developmental Disabilities. I'm here to highlight the importance of language access for deaf and hard of hearing individuals during childbirth as it relates to SB 192. For individuals whose primary language is American Sign Language, not English, communication barriers in healthcare settings can lead to miscommunication, medical errors, and trauma. And too often, deaf individuals must rely on untrained staff, inadequate technology, or family members to interpret during critical moments, which compromises informed decision-making and safety. And I know that a lot of the bill doesn't have to do with this, but we're super excited to see that included in there, and access to qualified live ASL interpreters is something that we advocate for. So thank you.
Thank you, Ms. Nielsen. Seeing no one else here in Carson City, we will go to Las Vegas. Testifying in support of Senate Bill 192. Please go ahead when you're ready.
Good evening, Vice Chair Taylor and members of the HHS Committee. Thank you for this opportunity to support SB 192. For the record, my name is Jolina Walker, Jollina, Walker, and I'm here to highlight the critical role that this bill plays in advancing women's healthcare access in our state. SB 192 is a necessary step forward to ensuring families have access to comprehensive, preventable, and equitable healthcare. Women face unique healthcare challenges from reproductive health to maternity care, and this bill prioritizes policies that support their well-being. SB 192 addresses health disparities that disproportionately affect women, particularly those in underserved communities. It emphasizes access to care, ensuring that socioeconomic status, insurance coverage, geography, and background do not serve as barriers to receiving high-quality preventative care. Importantly, this bill also recognizes the value of doula cares in improving maternal health care outcomes, especially in Black women and women of color and those living in rural communities. Comprehensive doula programs have demonstrated savings of $986 per birth in reduction of interventions and complications. This bill is more than just policy. It is a commitment to the health and dignity of women in our state. I urge the committee to support SB 192 and to help build a healthier future for women and their families. I want to thank Senator Neal for bringing this bill forward and my senator, Chair Danyate, for carrying it forward. Thank you for your time, and I ask that you support SB 192.
Thank you, Ms. Walker. Is there anyone else there in Las Vegas who'd like to testify in support? Please go ahead when you're ready.
Hi, good evening. My name is Kaylee Mancha. That's Kaleigh-Mancha. I am speaking in support of this bill in relation to the expansion of coverage for doula care. I am a licensed mental health therapist and certified doula, both roles I've held for 15 years this year, also co-founder of a local nonprofit that aims to reduce maternal health disparities in Clark County specifically. And I want to quote some statistics that I think put a really poignant focus on why doulas are impactful for reducing maternal health disparities. The Policy Center for Maternal Mental Health calculated the average healthcare provider spends 5.75 hours with a client or patient who is pregnant and postpartum versus doulas who spend an average of 76 hours during that same time frame during prenatal and postnatal care. I bring this up because the Society for Maternal Fetal Medicine reviewed CDC data from 2005 to 2022 and found that suicide and homicide are the #1 causes of maternal deaths in the US for pregnant women and women up to 42 days postpartum. Doulas do many things, but I want to focus on the educational aspect. We educate families about the early signs and risks for pregnancy complications. We discuss maternal mental health needs and warning signs, and we help families develop the skills to communicate with their providers. As a mental health provider, I know that it would be wonderful if we had screenings or other measures to reduce these numbers for maternal deaths, but the reality is that doulas serve as intermediaries between families and their providers, making sure they get the best care possible. Instead of burdening providers with doing more work, we're outsourcing it to people in the community who are trained and skilled to do this work. And I just want to point out that the Policy Center for Maternal Mental Health found in a survey last year that 91% of doula surveys felt mental health support was a critical part of their role. And so I support SB 192 in moving forward, enhancing people's access to
Thank you so much,
services.
Ms. Mancha. Is there anyone else in Las Vegas? Seeing none, and none in Carson City. AVH, is there someone on the phone line who'd like to support Senate Bill 192?
To testify in support, please press *9 on your phone to take your place in the queue.
Good evening, Vice Chair and members of the committee. My name is Akindele Kolade, spelled Kolade. I'm a board-certified psychiatrist in child and adolescent psychiatry, adults as well as in addiction medicine. I support this bill 192, specifically section 22.
Thank you so much. Next caller.
Eric Wilcox, EricWilcox. Thank you, Vice Chair Taylor and members of the committee. I am the parent of a deaf child and chair of the Nevada Commission for Persons who are Deaf and Hard of Hearing. The Deaf Commission routinely hears complaints from the community that we represent about difficulty obtaining adequate sign language interpreters in healthcare settings. And there really is an urgent need for renewed commitment in Nevada to providing access to qualified interpreting, which should be afforded to deaf and hard of hearing individuals under the Americans with Disabilities Act, but often isn't. And that is also including during childbirth as provided for in this bill. Therefore, the commission urges your support for SB 192. Thank you.
Thank you so much. Next caller.
Hello, my name is Cristina Hernandez, spelled Hernandez, and I'd like to voice my support for SB 192. First, I'd like to thank the sponsor of this bill. I sit on various maternal and child health coalition boards. I am a doula, and I'm also a mom who utilized a doula during pregnancy. This bill would provide support for many more parents that currently could use a doula. You've already heard the many benefits of a doula and how they can provide for families during pregnancy, labor, and postpartum. And as we continue to hear about the high rates of maternal and infant mortality throughout this country, and with the current cuts to maternal and child health, this bill will increase the much needed access that our families deserve and need. This bill provides some of that relief. So I'd like to thank you for your time, and I urge you to vote yes on SB 192.
Thank you, Ms. Hernandez. Next caller.
Good evening, Vice Chair Taylor and members of the committee. This is Sue Birch, Sueburtch. I am the Executive Director for the Nevada chapter of the National Organization for Women, and we strongly support SB 192. It may be a huge bill, but it is a necessary bill, and we urge you to pass SB 192. I want to thank Senator Neal for bringing this bill forward, and Senator Doñate for presenting it today. And thank you to all the presenters on this very, very important bill. Thank you for your time.
Thank you, Ms. Birch. Next caller.
Chair, there are no more callers in support at this time.
Okay, thank you very much, AVH. And now we will open it up for opposition to Senate Bill 192. Again, we will have 15 minutes for opposition, and you know the rules. State your name, spell it for the record, and you'll have 2 minutes.
Good evening. My name is Patrick Kelly with the Nevada Hospital Association. We're very happy to hear that Senator Neal's recovery is going very well, and we look forward to discussing our concerns with the bill when she returns. Thank you.
Thank you so much.
Vice Chair Taylor, for the record, Shelley Capro representing the Nevada Association of Health Plans, which is an organization comprised of 10 health plans working in both the commercial and public markets. We appreciate the opportunity to express our concerns with SB 192. The bill restricts the ability of multiple healthcare companies from operating within the state and prohibits their ability to provide integrated and coordinated care. This would impact the treatment of hundreds of thousands of Nevadans. The health plans also have concerns within the bill over mandated treatments. We do look forward to working with the sponsor and coming to a resolution that upholds the care choices of Nevadans. Thank you.
Thank you, Ms. Capurro. Please go right ahead.
Thank you, Vice Chair, members of the committee. Blaine Osborne, Nevada Rural Hospital Partners, for the record. I think the bulk of our concerns center around Section 1, Subsection 1, and the real challenges that rural hospitals would face being able to comply with that provision. So ditto to the other comments. We look forward to working with the senator and the sponsors on this bill. Thank you.
Thank you, Mr. Osborne. Please go ahead.
Good evening, Vice Chair Taylor, members of the Senate Health and Human Services Committee. It's Joanna Jacob on behalf of Clark County. Just here under the rules of the committee, earlier this week we did have the opportunity, thankfully, to talk to Senator Neal. It was very good to hear her voice as everybody has expressed. And thank you to Ms. Cooper and Senator Doñate for helping facilitate that conversation this week. We wanted to get on the record specifically only on Section 22, which is the section requiring child welfare agencies to do a psychiatric evaluation of a child before they were to exit the system for permanency. We have a couple of technical things that we have already discussed with Senator Neal. We really wanted to come up with language that it's consistent with her intent, which, as I understand it, is to make sure that the kids are getting an evaluation before they exit the system, and that evaluation should be independent. In order for us to do that, we wanted to work with her on the language of the bill to make sure that we could get an assessment, maybe with other types of healthcare providers, particularly if it has to be an independent evaluation. In Clark County, there are very few child psychiatrists, and we contract with all of them, so that would be difficult for us to meet that requirement of the independence of the evaluation. So we are working, and I think we are pretty close, working on an amendment with Senator Neal on that. We do have children who exit to permanency in under a year. So to do a second evaluation, it might run into some difficulties. So we're working through some of those issues, and I think that we're going to get there. And we hope to get to neutral with the amendment, and we're going to talk to Senator Neal after the hearing today. Thank you.
Thank you, Ms. Jacobs. Please go ahead.
Good evening, Vice Chair Taylor, members of the committee. For the record, Cadence Matievich, representing Washoe County, CADENCEMATIJEVICH. In the interest of time, I will concur in the comments that Ms. Jacob from Clark County made. We appreciate Senator Neal's understanding of our concerns and willingness to work with us. We look forward to addressing those concerns and coming forward in support of the bill in the future. Thank you.
Thank you, Mr. Matievich. Please go ahead.
For the record, Ryan Beam, representing the professional firefighters in Nevada. Appreciate Senator Dante for meeting with us and trying to address our concern in one section of the bill. We'll continue to work with him and appreciate that. Thank you.
Thank you so much. All right, seeing no one else in Carson City, we will go to Las Vegas. This is testimony in opposition to Senate Bill 192. Please go ahead when you're ready, sir.
Good evening, Vice Chair Taylor and the rest of the committee. My name is Damon Schilling, SCHILLING. I'm the Director of Government Relations for Intermountain Health here in Nevada. We have not had the opportunity yet to speak to Senator Neal, but we do look forward to working with her. We're happy to hear her voice, and we wish her a speedy recovery and look forward to working with her when she does return. But we are here today in opposition of Section 26 of 192, which would prohibit a healthcare organization from also owning and operating an insurance company. This provision directly threatens Intermountain Health's integrated healthcare model, which has proven to improve patient outcomes, reduce costs, and expand access to care in Nevada. Intermountain has successfully operated both a healthcare system and an insurance plan, Select Health, in a way that prioritizes patient-centered care, affordability, and efficiency. By aligning the financial and medical aspects of healthcare, we can reinvest savings into better services, preventative care, and innovations that ultimately benefit patients and the communities that we serve. If SB 192 were to pass as written, it would force Intermountain to choose between providing care and offering insurance, effectively dismantling our ability to deliver value-based healthcare in Nevada. This disruption would not only harm our patients, but would also have devastating consequences for our clinics, primary care offices, and the children's hospital we just recently announced, which relies on our integrated model to secure sustainable funding, lower cost of care, and provide critical services for families in need. Nevada already faces a shortage of healthcare providers and high costs for patients. Disrupting a system that is actively working to address these issues is limiting and harmful. Instead of dismantling successful integrated models like Intermountain, we urge the committee to support policies that encourage innovation, affordability, and access to high-quality care. For these reasons, we strongly oppose Section 26 of SB 192 and urge the committee to remove or amend this provision to protect patients' choice in healthcare in Nevada. Thank you.
Thank you, Mr. Schilling. You must have rehearsed that because that was 2 minutes on the nose. All right, seeing no one else coming forward in Las Vegas, AVH will go to the phone line for opposition.
If you'd like to testify in opposition, please press star 9 on your phone to take your place in the queue. Vice Chair, there are no callers in opposition at this time.
Thank you so much, AVH. And now we'll open it up for neutral testimony. Any neutral testimony here in Carson? And if there's neutral testimony in Las Vegas, please come forward at this time. Go right ahead when you're ready.
Thank you, Madam Vice Chair, members of the committee. Adam Plain, Plain, with the Nevada Division of Insurance. The division is neutral on Senate Bill 192 as a matter of policy. We did note that we reviewed the two benefit mandates in the bill for federal deferral provisions. For the purposes of doula services, it appears to us by our evaluation that we're really just adding a new provider type and not really adding additional services, so that would not trigger federal deferral. On the testosterone replacement therapy, the division notes that existing statute 689A.0415 sub 1 does currently require coverage for any type of hormone replacement therapy, emphasis added on my own. So we've read that the testosterone replacement therapy for menopausal women would be a subset of that. And since we already require any replacement therapy, it's already covered. I would say if there are consumers in the state under a fully insured commercial plan that are not experiencing that, they should probably contact our consumer services section, and we can walk through the steps with them and see if maybe their coverage should provide that. Additionally, we've had some communications with Senator Neal. We do have one of those proposed amendments on Nellis. It's our understanding that she's amenable, but I don't want to speak for her, obviously. But what we found is it looks like in the drafting, there are 8 particular sections that may have inadvertently caught up some provisions. In Chapter 682A, dealing with how real estate is owned by health insurers, and in 695C, dealing with health maintenance organizations employing physicians. It's important to note that the investment of real property for insurers is a state accreditation item for the Nevada Division of Insurance, and the proposed changes in the original bill would put us out of accreditation requirements. So it's important that we perhaps don't make those changes. That's the amendment. And in 695C, a health maintenance organization is kind of by definition an amalgamation of physicians, and so they kind of need to be able to employ physicians. So those are our suggestions, and we'll work with Senator Neal.
Thank you, Mr. Plain. Appreciate it. Anyone in Las Vegas for neutral testimony? Seeing none, we will go to the phone lines. AVH, is there neutral testimony on the phone line?
Testify in neutral, please press star 9 on your phone to take your place in the queue. Vice Chair, there are no callers in neutral at this time.
Okay, AVH, thank you so much. Senator, no closing remarks? Way to read the room? Okay, we will now close the hearing on Senate Bill 192 and turn our meeting back over to the chair. But as he's coming, if you're here for public comment, please come forward at this time here in Reno or in Las Vegas. Chair.
Thank you so much. Now that the bill hearing has been closed, we'll move on to our last agenda item, which is public comment. If there's anyone here, seeing none here in Las Vegas, AVH, is there anyone online?
Participate in public comment, please press star 9 on your phone to take your place in the queue. Chair, the public line is open and working. However, there are no callers at this time.
Thank you so much. We'll go ahead and close public comment, and I appreciate everyone for coming. I do have some good news. My nephew was just born, literally while we were in this hearing. Right. So Sebastian Thiago Doñate is my second nephew. So, yeah. So it's a good moment to end this meeting. So my mom just texted me about it literally while I was coming up here right now. So that concludes the work of today, and we will go ahead and see everyone on Tuesday. So thank you so much, and meeting's adjourned.